good afternoon, and welcome to the City Case Studies from African Cities session. My name is Yolanda Manuel, and I am the IAPAC's Regional Director for Southern and Eastern Africa. I'm based in Maputo, Mozambique, and a relevant part of my work is related to the Fast Track Cities initiative. I would like to welcome you all for this first session on the African City Case Studies, and we will have 6 cities for this session. 3 cities will be presenting here in the room, and 3 cities will be joining virtually. After the 6 presentations, we will have hopefully 10 minutes for Q&A, and I encourage you all to participate in this session and ask the questions to all the presenters. Well, with no further delays, I would like to invite Mandalisu Juaweni from Blantyre in Malawi to deliver his presentation. Mandalisu is the program manager at the Forum from AIDS Counseling and Training and will be joining us virtually. The topic of the presentation is Intergenerational Relationships, a risk factor for HIV prevention among adolescent girls and young women in Blantyre City. So if we are ready, please. We just can't. We cannot hear the presentation. Okay.
Hello.
Now you.
Hello. Can you hear me?
Yes, we can hear you now. You are welcome.
All right. Thank you very much. All right. Good afternoon, everyone.
But we are not seeing the slides.
You're not seeing the slides?
No.
Okay. Let me work on that.
I believe that you have to share the slides, but we also have the slides here. Just let me know, how do you prefer to do it?
I think it's okay. You can go ahead and share it, the last one that I sent last night.
Okay, you will share the slides then.
No, you can share because
okay.
In my end, it's showing like I'm sharing, so I'm surprised that you can't see. I had asked in the chat if you're able to see my slides, so I got the answer that they can be seen.
Hi, can you please open the presentation so that we can see the slides?
Okay.
Is that possible for us to share the slides and then I can go?
It's not possible, but
okay, just
open because it's already sharing the screen. So
it's fine, just share the presentation. I will.
Es la primera, ¿no?
Sí.
Okay.
We can share the slides, otherwise. Okay. Can you see the slides now?
Yes,
okay.
yes.
Just let me know when you want to go to the next one. When you're ready.
Okay, fine. Yeah. Yes. Okay, welcome back once again. And good afternoon. As you have already heard, my name is Madaito Joy, and I'm the Programs Manager for Forum for AIDS Counseling and Training, a youth-led organization in Blantyre City. I'm here to present on a case study on one of the issues that came out during the implementation of City's Fast Track project that Malawi was doing with Blantyre City as well as UNAIDS. During the implementation of our project, the issue of intergenerational relationship was strongly presented. Intergenerational relationships, these are relationships. You can go to the next slide now. Intergenerational relationships are relationships that young people, adolescent girls and young women of the ages 14 to 24 enter into with elderly men that are aged 45 to 75, and are usually for a sole reason of exchanging sex with money. And in our contemporary society, these intergenerational relationships have been nicknamed blessers. You can change the slide. Going forward, I'd like to take you back on the implementation that FACT Malawi was implementing with the city's Fast Track and UNAIDS as well as Blantyre City. FACT Malawi was presenting a project that was working on increasing demand for young people to seek HIV testing services. This was very important because culturally, young people in universities within Blantyre City engage in sexual relationships without knowing each other's status. So our project was to create a culture in their heads that they need to seek HIV testing services before they engage in sexual relationships. And of course, we were also trying to reduce the number of new HIV infections among adolescent girls and young women, as well as young people in general. As you already know, most of the new HIV cases that are coming up in Blantyre City are those among young people, especially adolescent girls and young women. During the implementation of this project, we had HIV testing services. We also had linkages to ART for those that tested HIV positive, as well as the sharing of IEC materials, as well as linkages to PrEP, STI screening and counseling, and condom distribution and promotion. It is also good to note that this was not only done physically, but we were also able to do the promotion on our social media pages. During the implementation of this project, we came across the issue of young adolescent girls and young women being at a higher risk of contracting HIV compared to their male counterparts. In rubbing more on the issue of why adolescent girls and young women are on a higher risk and are presenting with more HIV positive statuses compared to their male counterparts, we came across the issue of intergenerational relationships. In engaging with these girls, we found out that most had tested HIV positive. They are girls that were in relationships with elderly men, which made it hard for them to negotiate for safe sex. Rubbing more, we found out that keeping condoms is also a culture that is not popular among adolescent girls and young women, because keeping condoms will make them look like hoes or sex workers, so to say. And also, most adolescent girls and young people presented to be more afraid of getting pregnancy compared to contracting HIV. When we looked more on the issue of intergenerational relationships, which are commonly called blessers, these elderly men that the young people enter into a relationship with, we found out that most of the reasons why these elderly men are very popular among the young people is because they are sponsors of the lives that these young adolescent girls are trying to live. To cement this, one local newspaper had a cartoon that was printed in the newspaper that showed that said that government would make a lot of money if it was to have a toll gate on the road going to the university hostels within Blantyre City. This is just to prove that there is more traffic of cars going in and out of the universities in Blantyre City, especially at night and during weekends. And the owners of these cars are the blessers, that are the elder men that are dating these young girls. Talking to one girl on why she is in a relationship with a blesser, and this girl had also tested HIV positive at our HIV testing center. She said that she had a party planned and she didn't have enough money to sponsor this party. So in the end, she decided to find someone who could sponsor. And the person said he could only do it if they have sex, and she agreed. So from this story, we can see that the issue of living up a certain life and showing off to their friends is also, it's one of the reasons that is prompting most adolescent girls and young women to enter into these relationships with blessers. And there is also an issue of slay queens. Slay queens are girls that are also trying to live a life that they cannot afford in the university campuses. Talking to one girl from one popular university in Malawi said that the competition to keep a blesser and to look good is very high on the market in the universities. One has to maintain looking good if they have to keep their blessers, or their friend may snatch them away. To make sure that they're still looking good to their blessers and they're more attractive, most adolescent girls and young women end up having one or more blessers, so that they have a blesser who sponsors their outlook, the blesser that can pay for their school fees, buy groceries, and also sponsor their rentals. We also had a conversation with one girl where we found the issue of sexually transmitted grades. The issue of sexually transmitted grades is an issue that is very common among the adolescent girls and young women in campuses, because these girls tend to use their lecturers to give them grades when they miss school. So in exchange of getting these grades, they end up sleeping with their ex-lecturers, which are also elderly men in the category of blessers. Because they are in a pressure of getting these good grades, these girls don't have time to negotiate for safe sex, and they end up having unprotected sex and in the end contracting HIV. On index testing, we found that one girl would present more than 3 indexes for people that she had been involved with, and 2 of these people mostly are the blessers. During a rapid assessment, we found out that more than 10% of all adolescent girls and young women in public universities have had a sexually transmitted grade at one point in their campuses. In conclusion, my dear listeners, I would like to say that the issue of intergenerational relationships, blessers, is a very big problem among adolescent girls and young women in Blantyre City universities. And there is need for more research and more investment to be put and look into this issue and find out how these intergenerational relationships are leading to high numbers of HIV positive rate among adolescent girls and young women. I believe that together we can work to reach our goal of ending HIV by 2030 if we invest and do more research into this area of intergenerational relationships. Thank you very much. Gracias, Ziko Mokwambili. Thank you.
Thank you very much for your presentation. I'm sorry that the slides were a bit slow, but thank you for your presentation. Please save your questions. We'll be discussing at the end of this session. We will now move forward to the second presentation of this afternoon. I would like to invite Etiqueni to deliver the presentation, and Malokuwani Ntabiseng. She is the District AIDS Coordinator, and she will be delivering a presentation named Etiqueni PL-HIV Lead to the Way of HIV-Related Awareness, Education, and Response at a Community Level. The floor, it's all yours.
Thank you very much. Good afternoon, colleagues. I'll be presenting on how PL-HIV lead the way in eThekwini as I've got 15 minutes. Okay. I'm not going to dwell much on this slide, but just to state that at eThekwini, we have 111 wards, which are clustered into 17 zones. And we have about 17.1 with no income. And we are struggling also with child-headed households. As you can see, we've got about 8,802 child-headed households. The population of PLHIV in eThekwini is about 6,072, and we also have 28% of all HIV transmittable. Can I just go back? I just don't want to miss the part about children living with HIV that are not on ART, which is our biggest concern. As you can see in the photo, we have PLHIV support group where they sit and discuss the plan moving forward, and we have a youth HIV museum that we use for them to have those discussions. This is our biggest concern. We only have about 52% untransmittable, and we're sitting with 28% transmittable, which is a big concern, and we still have about 20% that is unknown. So this is a big issue for us as the city, and we are trying to find strategies of how we can really change this pie graph. Our challenges, we're doing well on diagnosis, but we're really struggling with viral suppression. There are many factors that contribute to getting to the dead 90 of viral load suppression. Sometimes they are reasons that make people default treatment. U is equal to UN treatment as a prevention concept is well known and understood among the PLHIV and our communities at large. We still have the issue of self-stigma. Support groups and Adrian Club have stopped functioning. This calls for PLHIV to do a revitalization of the sector itself. So the focus also is the sector needs to include more young people living with HIV, youth living with HIV, to form part of the sector as we re-establish the sectors. Children living with HIV left behind. We have a challenge, but our mayor has committed to make sure that we bring about 11,000 of children back to on treatment. The need for collaboration amongst partners provide different packages. We work with different partners, and we always say, let's work in a multi-sectoral so that we are all able to have one plan, and we all understand the plan, which will take us forward. Community ownership of the response is weak because what AIDS committees are not functional. We have started working on that. The What AIDS councils are led by councillors, and we are bringing them on board. We have been training, and the training is led by PLHIV. Okay, our solution, PLHIV lead the way to community awareness and ownership of the HIV response. As you can see in the picture, this is Ms. Zonke. She is our PLHIV chairperson in the city. This is a poster that we have that we send to all facilities, including other community centers, so that we sensitize the communities, and also they can reach out to our offices, as you can see our numbers below. Eastern municipalities also prioritize support for PLHIV leadership of the community response. I think we are on the right track, because currently we are training the What AIDS Council, but the training is being done and led by PLHIV sector leaders. And also the revitalization of support groups and adherence clubs. The training of traditional health practitioners, and also we're doing treatment literacy. But the traditional health practitioners are really coming on board, working together with the PLHIV sector, and they're working very well. They understand also their role as the traditional practitioners to say, let's also have, they must also have a voice in the community and also sensitize people, because you know sometimes, especially where we come from in South Africa, you'll find when people get ill, they decide they start at the traditional healers center then to go to a clinic. So hence there is a need to really train them and capacitate them as well. The Office of the Mayor is working well with the sector, and we are providing support. We coordinate services which are led by them. When they say the reason why people are defaulting is 1, 2, 3, and 4, and we say what needs to be done. And we work with them, we plan with them, and they lead the way. We have human resource in the office that supports them, take them to different areas of the city where they need to conduct trainings. We also provide venues and refreshments for the training. We get also a support from the Office of the Premier in the HIV Directorate. They really support us as eThekwini because they have always been saying, once you remove eThekwini in the province, KZN will not be leading in the new infections. So they really try hard to come on board and make sure that eThekwini really is working towards ending HIV. Okay, why PLHIV leadership? We want a generalized epidemic. Anyone can have HIV. We don't want to say, say certain people or certain areas. We are saying anyone in the city can have HIV. So let's just generalize it so that we avoid the issues of stigma. We also understand that the people living with HIV understand the journey better than anybody else. They've walked the journey, they understand, they've also defaulted, they've been through the different stages, so they can tell the story better. PLHIV understands the response as well. So that is why we work very close with them as the District AIDS Council that is chaired by the mayor, and we make sure that in that forum, we deliberate on issues that affect them, because we always say that the backbone of the District AIDS Council is PLHIV. So once we understand that, we will know that in the youth sector, you have youth living with HIV. In the men's sector, we have men living with HIV, and in other sectors as well. You can see there our mayor with the chairperson of the PLHIV sector in the city, and also on your right-hand side, we have the secretary of the province PLHIV sector, and we have Ntokozo, youth living with HIV. So this picture, tells many, it can tell you a story where they were taking the mayor through. Okay, we are creating awareness by building capacity in the communities. And this has been working very well, colleagues. We do it through the conversation map. As you can see, the chairperson taking them through the conversation map. And we also, they also understand the HIV statistics. They understand the HIV science. The U is equal to U. They understand it, really in a true sense. The response to HIV structure, strategies, plans, and interventions. We do a community profile. We map the partners, plan strategies, report on activities. And our activities are always informed by what the data indicates, what is the stats saying, what is the report saying, just before we submit the report to the Premier's office. When we sit in our District AIDS Council a meeting, we deliberate more on the report and what needs to be done. The journey of PLHIV and the conversation map, you can see clearly there our conversation map. We've expanded the use of the conversation map for PLHIV as a teaching tool. Now, this, I know most of the time when they go to communities and they take the communities through the conversation map, it makes the communities understand easy. It is so simplified that anybody can understand and anybody can see that it is doable. Once you have been diagnosed and you are still in the hiding, you are not taking your treatment, you then understand better the need of taking your treatment. Understanding of the journey of the PLHIV is very important in community awareness. You can see there, this is the mayor and this is the ward councillor. That is why we are saying the PLHIV is leading. You can see the chairperson taking the mayor through the conversation map, and on the other side you can see the councillor and the mayor discussing. That's the ward councillor discussing. Okay, PLHIV leaders were trained on the ITPC. So they understand, they are capacitated, they know, and it has helped them as well to understand better and to be able to take to train others in the community. The community, the feedback from the community after the trainings, we have been receiving very positive feedback. The community is requesting PLHIV to come back and train them, is requesting also, even social development has requested them to please assist them with training of their local NPOs that are funded by the department. Thank you very much. You can see the photos there. There is the training with ECD practitioners, and you can see there Zonke leading the training, explaining to the group, and that was the ITPC training break. Thank you very much.
Thank you. Thank you, Tabiseng, for sharing the experience of eThekwini, where the PLHIV are leading the HIV response at the community level. Thank you. We will now move to Kinshasa, Democratic Republic of Congo, and I would like to invite Dr. Faustine Kitetele to deliver the presentation. He will be joining us online virtually, and Dr. Faustine is the head of Infectious Disease Department at the Kalembele Lele Hospital. The presentation will be around the contribution of peer educators in the HIV status disclosure, adherence and retention in treatment to adolescents and young people living with HIV. The floor is yours, Dr. Faustine. We would like you to share your screen so that you can control your slides.
Thank you.
Can you please share the presentation so that you will be able to?
I think it's okay. Is it okay?
No, not yet.
I share the presentation.
I think that we are having some problems. Okay, now we can see the presentation.
Okay, thank you very much. I am Dr. Faustine Kitetele. I work at Kalembelembe Pediatric Hospital. The title of my presentation is Contribution of Peer Educators in the HIV status disclosure, adherence and retention treatment to adolescent and young people living with HIV. It's not my presentation, it's for Dr. Lembe Virginie. Is it out of the series?
Could you, excuse me, Dr. Faustine, could you please click on show so that we can see the whole slide?
Please?
Okay, it's fine, we can proceed, you can proceed.
Please, will you repeat, please?
I was asking you to click on show so that we can amplify, how can I say, The presentation, yes.
Okay.
Thank you, thank you.
Is it okay? Okay.
It is, thank you.
Rationale. Several approaches to the disclosure of HIV status have been described, each of which places particular emphasis on the role of parents, provider of psychosocial, to mitigate the impact of this disclosure on the adolescent, but often underestimate the participation of peers. Very few providers are trained in the HIV disclosure process to adolescents. In this fact, Kalembelembe Pediatric Hospital in GRC train adolescents and young people living with HIV, like peer educators, to prepare their peers for disclosure and to ensure full disclosure under the supervision of healthcare providers. Given the number of our facilities, the distances to be covered, and the number of sessions before the complete announcement by our peer educators, we have improved our approach by integrating the remote preparation of adolescents by video conference, while the complete announcement is face-to-face or peer-to-peer. An example, remote announcement process by video conference, by Zoom. In the first pictures, we see peer educators preparing peers remotely via Zoom. In the second photos, adolescents in the process of disclosure by video conference in the other hospital. The first photos at Kalembelembe Pediatric Hospital, the second photos another hospital. And the third photos, complete announcement face-to-face peer and peers group. The peer educator go to join the adolescent who are ready to receive the complete announcement. We assess the disclosure process by adolescents living with HIV. This table compare the disclosure carried out by peer educators to other actors. If you see the disclosure by biological parents, only 14 adolescents are present. By healthcare workers, 80 adolescents are present, but by peer, all adolescents appreciate this approach. By guardian, only 14 adolescents appreciate it. For us, the process of disclosure by adolescents is the best method because the majority of adolescents appreciate it. We assess the disclosure process. We explain some excerpts from the disclosure adolescent. A 15-year-old said, "When I was told, I started crying. It felt like the sky was falling on my heart, but when she had that she was born with it too, I stopped crying. I looked at her and started to listen to her attentively. She suddenly becomes interesting. As she spoke, she transformed me, she calmed me down, and she finally convinced me. She became my confidant and the game changer of my life." Another, a 13-year-old boy, explained, "I refused to get in touch with peers because I did not know that they were also concerned. One day, I got into a meeting of a SAFO group, and I understood that all these young people that I saw and wanted to be like them were not different from me. It was a new birth for me." On the other hand, An adolescent, the 70-year-old declared, I never accept this situation and to forget. I try to relieve myself by using cannabis and indulge in sex. How can my parents, who are responsible for my pain, wake me up at night to advise me to take the medicine properly, or I will die because I have AIDS? In front of my tears, they went to their bedroom and we did not talk more about it. A 14-year-old girl often said, I was dead right away listening to my husband screaming on her in the night, telling her that he did not want to see me at his house for fear of contaminating his children. The next day, my aunt will come to abandon me at the hospital. Lesson learned: adolescents living with HIV whose disclosure involved peers and was recognized that the latter in accepting their HIV serological status and development self-esteem. Literature on the key appropriate person to the disclosure seems controversial. Existing literature shows that adolescents living with HIV and their caregivers prefer disclosure by caregivers with assistance with healthcare workers as they have accurate knowledge of HIV. However, for the vast majority of participants in our study, the key person in the disclosure was the peer from or is their direct involvement in all stages of the process, including the self-support group. Conclusion, we found that the HIV status disclosure process is one of the most important factors that allow adolescents living with HIV to accept their HIV status with minimum distress. Adherence, retention to care and treatment, self-esteem, and risk of depressive symptoms result from the dynamics of the relationship between peer educators and adolescents living with HIV and psychosocial support. Thank you.
Thank you, Dr. Faustin, for delivering the presentation, and thank you for your availability to join the event, because we know that we are not the original presenter. Thank you. Please stay tuned, because we'll be discussing at the end of the session. We will now move to Maputo, Mozambique, and I would like to invite Dr. Bélia Nyambir, the Director for Health at Maputo City Council, to deliver a presentation related to the male engagement in the primary health care. Doctor, please. You have 15 minutes.
Thank you, Dr. Yolanda. My name is Bélia Shirinda from Maputo City Council, and my presentation is upon Maputo's experience on male engagement in primary health care. These are the outlines of my presentation. This is the map of the city of Maputo, that is the capital of Mozambique. We have a population of 1,130,319. We have 7 districts, 42 health facilities that have ART, 24 health facilities that are implementing the strategy of male engagement, and we have 168,886 patients under ART. And we have 24 health facilities with champion man strategy. Also in the second picture, we can see the male engagement guideline that was launched in 2018 by the Ministry of Health in Maputo, in Mozambique. Since then, we are implementing these strategies. In Maputo, we have HIV prevalence of 16.9%, one of the highest in the country, and the country has a prevalence of HIV of 13.2%. This is the dashboard of fast-track cities that we have in Maputo, and we have the photo of our mayor. To contextualize, men have very low rates of care and treatment, leading to high rate of HIV morbidity and mortality. Men talk less about their feelings and rarely seek help due to gender norms and taboos, as we know. Weak presence of men in care and treatment in the health facility, while women are still dependent on men. Not a friendly environment for men at the maternal and child health care. They are always asked, well, the professionals are always asked the man where the mother is when he's with his child. Why engaging men? It's very important to engage men because health indicators of men and boys are lower when compared to women and girls. 52% of HIV new infections occur in men, aged 15 to 49 years. ART coverage in 2020 among men was 62% compared to 73% among women. And more men die from preventable causes such as malaria, tuberculosis, HIV, cardiovascular diseases, accidents, and injuries. Well, because of this, priorities interventions were defined, such as to promote friendly services for men and couples in health facilities, including at workplace, to promote the use of health services by men and couples through the transformation of social norms affecting the use of health care, promote the participation of men as a partner in PMTCT programs, increase knowledge about the use and adherence to healthcare by men through the implementation of communication strategies to change behavior. And these are the basic principles for implementing the activities, namely health promotion, recognition of HIV/AIDS as a problem of both genders, non-discrimination, gender equality, social dialogue, confidentiality, and prevention. We have implemented some activities at 4 levels. First at the health facility level, then at the community level, then at the workplace level, and also at other levels. At the health facility levels, we undertake lectures and morning sessions specially tailored to involve men, identification of male engagement focal point responsible for coordinating male-related activities, development of terms of reference for the male engagement focal point, introduction of quarterly meetings to discuss the male engagement strategy, meeting participants including labor sector, health facility focal points, health partners, civil society, and also governmental officials. And still, distribution of information, education, and communication material related to male engagement in all health facilities, as we can see in one of Maputo's facility, that they have this material. Massification of the partner testing strategy, implementation of integrated male health care in the health facilities, identification of men engaged in health facility, and we can see in the second picture, we have 2 men with their babies. So they brought their babies to the health facilities. So this is a very nice thing to show. Creation of informative corners for men in all health facilities. At a community level, training of community activists in HIV, champion men also trained, individual and collective discussion with men in neighborhoods in places of greatest concentration of men. We can see in both pictures, and also provision of health service focused on men, that we offer many services like counseling, STI screenings, TB screenings. And we can see here in this photo a mobile clinic that have all these services that we take to the community. At workplace level, we signed a memorandum of understanding with the National Confederation of Economic Association in Mozambique to support implementation of male engagement activities in the already identified workplaces, wide dissemination of the male engagement strategy through the national radio and the public institutions, the most important institution and the biggest one that we have in Maputo, ongoing dissemination of the strategy in collaboration with the city health partners and local associations, fighting against HIV, and in institutions, prevention services are being offered, such as counseling, screening of STIs, measurement of BP, and many, many more. At other levels, we are doing meetings with religious leaders and civil society. We can see in this first picture. Also training of activists who are church members, participation in television programs, and also in radios and other social media networks. Well, what are the results implementing this strategy? In 2017, we can see the total male partners present at antenatal appointment were 6,726. Over the years, we can see the increase. At 2021, we can see that the number really is different. We have 21,831 male partners present at antenatal appointment. And partners tested at 2017, before the strategy started, we had 6,811, and 2021, last year, we had 20,086 male partners tested at PMTCT. Male partners tested positive at antenatal appointment. In this graph, we show that we can see that in 2017, we had 693. Over the years, the number decreased. In 2021, we have 295. About the total men tested in Maputo City, we have here also the positivity rate. In 2018, the positivity rate was 7%. In the following year, the positivity rate was the same. At 2020, the number decreased, and now in 2021, last year, we had a positivity rate of 5.3%. So we can see that the number decreased, even though the number of tested really increased. Well, to sum up, these are good results. We have the improvement in men's participation in healthcare, improvement in the involvement of men in the care of his family, reduction of new infections, improvement in HIV testing of men and early start of ART, empowerment of men in health care. Also, improvement perception of positive paternity and follow-up of women in health care, improvement in the knowledge of male duties and rights within the health facility, improved knowledge regarding gender equality, improvement in the demand for prevention services such as counseling, condoms distribution, PrEP, and circumcision, etc. We have, of course, perspectives. We want to expand these services for more health facilities. As I said in the beginning, we are doing only in the 57% of the health facilities in Maputo, so we want to expand, and we will expand next year. And the second perspective is to implement more communication strategies to really change behavior. We have learned many lessons with these strategies, that it is possible to include men at the antenatal consultation, that they can really go with their spouse to the consultation, and also that these corners of men are really important because these men can gain more information about HIV. Muito obrigada, Kanimambo, gracias, thank you.
Thank you, Dr. Belia, for sharing Maputo's experience when it comes to engagement in primary health care. From Maputo, we will now move to Nairobi, Kenya, and I would like to invite Anthony Kiplagat. He will be joining us virtually to present the Nairobi City Journeys Towards HIV Program Sustainability. Anthony Kiplagat is the head of HIV/AIDS unit at Nairobi Metropolitan Services. We would like to ask you to share the presentation so that you will be able to control the slides. And the floor is all yours.
So good afternoon. My name is Kiplagat Anthony. Hope you're able to see my slide from your end. Kindly confirm.
Not Not yet.
I'm not sure, but because I've already shared, so I don't know if you're able to now
Okay.
to view.
Okay, maybe. Okay, now we can see the slides.
Okay, so I can proceed. So as a Nairobi, we appreciate the support that we've been getting through the UNAIDS and for the IAPAC in especially implementing the Fast Track Cities initiative. And just for us, we're asking ourselves these difficult questions. Yes, we do appreciate especially the financial support that we get for the HIV program interventions, which we are targeting especially the adolescents and young people, but also the key populations. But what next if these funds either, or the project comes to an end or we do no longer get these funds? What next? So I just wanted to have kind of a discussion on how we can look at it. And so one of the things that we've been looking at in terms of sustainability is when we started the Fast Track Cities, and I remember clearly it was in around 2017, 2018, we had to sit down as a county together with our stakeholders, that is the Fast Track Cities and the Fast Track Cities in representative, that is UNAIDS and also IAPAC, just to look at where our gaps are and identify where our challenges are and how best can we address those challenges so that we're able to achieve our main goal of towards epidemic control for HIV. So one of the things that we did is also looking at our plan here in Nairobi County. What are some of our plans that we have, the long-term strategic plans that we have, and we need to align our activities towards that so that when you are responding, it's based on the already identified needs within the strategic plans, and also our interventions are anchored around that. So that was one of the things that we did. The second thing is very important is also the issues of partnership and how you engage your partners. And here we were looking at not only partners who are health sector players, but also the non-health sector players, but an important thing is also the community. So we were engaging each and every one of them to just get their views, especially on how we can proceed and implement this project. But also during our journey of implementation, we also had to sit down periodically to just review our progress and see, are we towards the goal that we intended to achieve at the end of each year in terms of our implementation, or we are deviating. And that has really proven to be important for us because we're able to share much about ourselves. And critical is also how we manage our knowledge, because every other time that we implement a project, and it's clearly even demonstrated from the presentation from other cities, you gain a lot of knowledge. But how do you manage this knowledge? Because it can be just any other knowledge without any use, but you have to sit down and look at it, share information, critically analyze your data, try to make meaning out of it. How can you apply it so that you have rich ideas that can also improve on programming going forward? And also critical for us is the best practices. What are some of the soft things that we've learned, or quick things that we've learned, innovative ways that we've learned so that we're able to implement and even beyond the funding cycle that we'll probably be getting. So that is very important for us, and that's how we looked at it. So we've been having periodic best practice sharing forums just to learn from each other within the county, especially within the different sub-counties here in Nairobi. The other very important thing is the issues of program integration. And we realize that resources are never enough. And the best way for you to improve your program efficiency and effectiveness, you have to really harness the little resources that you have and use it prudently so that you're able to maximize the benefit you get out of it. A case in point is like in key population and adolescents and young people services. Instead of running a parallel or a silo programming, we've decided that we need...
Excuse me, Anthony. We are still on the first slide. I don't know if you are changing the slides.
Yeah, I've been changing. Probably I may need to stop sharing and then once again come back. And now, are you able to
Yes,
view the slides?
the third one, yeah?
Yeah, so are you able to realize any changes from your end?
Okay. Yes, we can see now we are on the third slide now.
Yeah, so this is one I was talking about. So one of the things that we've done, especially in integration among the adolescents and young people and key population, we've really leveraged on our public facilities and even our partnership with the private sector, those private facilities that offer health services within the private sector, so that we're able to integrate services. And this will ensure that even beyond the funding, we're able to sustain and mainstream these critical services targeting these critical populations at each and in those facilities that have integrated the services. The other very important thing is that when you're even going to the communities, we will learn the act of also integrating services beyond what we offer in our facilities. And we do this even in during outreaches. Probably we take outreaches to the communities or in the villages or in the slums. And we offer the services including HIV, sexual and reproductive health, mental health, and every other services that is important for us. And for us, critical is also just to create awareness that we also in our facilities, we are able to integrate key populations and adolescents services. And very important is also on the messaging, and because the primary business for us is, apart from just offering treatment, is also the prevention of new infection. So we also try as much as possible to integrate services, especially the prevention services like the male's medical circumcision, the pre-exposure and the post-exposure prophylaxis, condom distribution, cervical cancer screening, and even for those who are living with HIV or those people living with HIV, we're also able to integrate the messaging around U is equals to U. Now, critical also to sustainability is issues around resource mobilization. I hope you're able to view the next slide. And for us, as a city that is also administratively, subnationally is a county, we need to align our planning, especially on issues around financing, to the national framework on health financing within Kenya. So we've tried as much as possible to align our planning within the national framework in health, so that we do not plan outside of what the national government objectives or the visions are. Secondly is, in Kenya, we have adopted the devolution kind of government. And here we have cities or counties that have semi-autonomous authorities that they can plan for themselves and budget for themselves and run their activities independently. And this is, so we take that advantage of that kind of governance so that we're able to resource mobilize locally within the cities to be able to have additional resources so that we can have our leadership being sensitized to understand the importance of proper prudent planning in supporting HIV programming, especially for these critical populations of adolescents and young people, but also beyond that, also having just a periodic review with our leadership, just to understand the progress made and the impact of that we've created through this planning. But also beyond there, we also resource mobilize even from our local business people and anyone who is willing to support us. But also remember, in HIV programming here in Nairobi, we also are beneficiaries of these other sources of funding, especially from Global Fund and PEPFAR. So every other time that we have our planning cycle, we try as much as possible to harmonize the resources. What is coming from the Global Fund, PEPFAR, what is coming from the UNAIDS, IAPAC, just harnessing those resources so that we are able to efficiently use the resources and be able to maximally impact on the communities. And just to mention is also that for us, we've adopted the issue of involving the communities also to be stakeholders in their health. And I know there's this famous slogan that there's nothing for us without us. So we also, as much as possible, try to also bring on board the people living with HIV, the adolescents, the key population, and everyone who is critical onto the table so that we're able to plan together, implement, but also review our progress together. So that is the end of my presentation. Asanteni sana. Thank you.
Thank you, Kip Lagarde, for your presentation. We will now move for the last presentation. The presentation will be made by Melissa Jane Lowe. She is from Windhoek, Namibia, and she is the Community Development Officer at the city of Windhoek. Melissa's presentation's topic is strengthening campaigns to increase adolescent girls and young persons' HIV prevention in the context of HIV. Melissa, the floor is yours. You have 15 minutes.
15 minutes. Okay. Good afternoon, everyone. Like our moderator said, my name is Melissa Jane Lowe. I am a psychologist by profession, but I'm currently working at the city of Windhoek in our social welfare section. So we are basically responsible for the social welfare of all of our vulnerable community members within the Windhoek district. Okay, so my topic, strengthening campaigns to increase adolescent girls and young persons, HIV prevention in the context of the COVID-19. Is that right? Okay, so that's just a brief overview of my presentation. Okay, just to give you a brief background of the city of Windhoek, it's the capital of Namibia. It's the social, economic and political, cultural center of the country. And nearly every Namibian national enterprise, all our government bodies, educational and cultural institutions are headquartered in Windhoek. So our current metro area population of Windhoek for this year is 461,000 people. It's quite small, right, compared to other countries. So our population for the country is 2.5 million, and that was in 2020, so I suppose we increased a bit. An estimated of 0.78% of female children under 15 years of age are HIV infected, while a similar statistic for male children is 0.79. HIV prevalence amongst people aged 15 to 49 years is estimated to be 16%, and that the total population of people living with HIV aged 15 and above is estimated at 260,000. The pictures that are illustrated there is just to show you the difference in our urban setting. So the top one there, that's our urban, our metropolitan area. And on the outskirts, we have our informal settlements, which is the picture below there, where people live basically in shacks, corrugated iron houses. They do not have access to proper ablution facilities, water, electricity, and that's where most of our infections come from. So approximately 230,000 families live in shacks in the informal settlement. That's countrywide. And in Windhoek, almost 40,000 houses have been surveyed during the 21 to 22 local government survey, which equates to approximately 156,000 residents in the informal settlement. So if you see that our population in Windhoek is 461,000, and then 156,000 of that live in the informal settlement. So it's quite big. Okay, so let me just get to my notes quickly. Okay, so during the COVID-19 pandemic in March 2020, all of our schools were shut down because that was the hub where most of the virus spread. So during the lockdown period, those young boys and girls who were at home were unfortunately sometimes left without supervision, and they didn't have access to, in the most affluent areas where education was now digitalized, they didn't have access to that. So many of them were kind of left to their own demise. And during that time, what we noticed was the teenage pregnancy increased tremendously because all of the girls and boys are at home. They don't really have much to do. Uncles and whoever are also at home. And unfortunately, through that, also a lot of gender-based violence increased. A lot of rape cases were reported as well. So we as the city of Windhoek, I can go on there, yeah. So what we as the city of Windhoek decided to do to try and curb the spread of HIV, GBV, and the increased pregnancy rates in the informal settlement was to take the services to the community. So what we did was we trained a core team of young people. We empowered them with basic skills to enhance their HIV competencies and to carry out outreach activities. So they were boys and girls. They were all very young people, very vibrant and very active and passionate about HIV and all of those others I mentioned. So what we did is we designed social behavior change communication materials, such as pamphlets, with these young adolescents and young people. And we identified 3 informal settlements in the Windhoek district which were most vulnerable, susceptible to teenage pregnancy, HIV/AIDS, and gender-based violence. So we went out to those 3 informal settlements, settlements first. And what we did the first day was our team, what we did for the first day is we went out into the community and we mobilized as many young boys and girls as we could. We gave them the pamphlets, we spoke to them just to hear what their understanding and feeling is about HIV, GBV, COVID-19, and then we invited them all to come to the next day where we had our actual outreach activities, where we had community mobile services along with counseling as well as social media. Oh, and in that picture there, that lady, the lady that you see there smiling so pretty, she's one of our team members. And then we've got 2 of our community members. The one lady's holding their pamphlet, and the photo is cut off a bit, but we have a lot of young teenage mothers, which we were very happy to see also coming to these sessions. The photo down there is just part of the group of team before we went out to the community, just have a small group meeting. And I don't know if you can see the bus in the background. So the city of Windhoek provided us with transport, municipal bus services to go out into the community. Okay, so all of this can obviously not happen if we don't work with partners. The city of Windhoek does not have the capacity to go out to all of the informal settlements, do HIV testing, counseling, information dissemination, and so forth. So we worked very closely with our Ministry of Health and our Ministry of Youth, UNAIDS obviously very much, and then AFRIAN is a group of young people who go out into the community and advocate for youth rights, sexual rights, and all of that. I could say that we worked very closely with them because they had the capacity to go out with us into the community. And then also NAPA is the Namibian Planned Parenting Association. So they accompanied us on the second day when we did our outreach with their mobile clinics. So what they then offered was family planning. So we were able to provide the community members with either oral or the injection family planning, also emergency family planning, for example, the morning after pill. We were able to give community members HIV counseling, antenatal care, STI screening as well as treatment, and we also identified, because of the high teenage pregnancy rate, the abortion numbers also increased, but in Namibia it's illegal to have abortions, so we had to do pre- and post-test counseling for these young girls as well. And then obviously we also definitely did some referrals. Condom and femidom demonstrations were also conducted to show them the correct way to use it and also to dispose of it. For the one informal settlement that we did our outreach, we were able to give out 1,140 condoms. So we were happy that the people are coming, taking what they need, and we were also able to show them how to use it correctly. We definitely faced some challenges. The informal settlements are situated quite far apart, so we spend most of the time traveling from the city center to, for example, there's a small peri-urban area called Groot Oop, and it's about a 30-minute drive, I think. So Namibia is a big country, but we're spaced out tremendously. So the spatial distribution is quite a challenge to us, for us, I mean. And then also poor visibility of the activities. We realized that we needed to spend more money on advertising these activities, which we didn't. And we felt like if we did more advertising, definitely more people would have been there. Transportation was also a bit of a challenge. Although we had the City of Windhoek municipal buses, they could only assist us during the week, and special arrangements then had to be made for our Saturday sessions. And then there was the language barrier. So all of our pamphlets were printed in English, and within one informal settlement, you can find maybe 5 different languages being spoken, and no one could speak English, so it was a challenge. We had to translate, our volunteers had to translate to the community members. Okay. So our lessons learned is definitely the good partnerships that we have with the other organizations. And then unveiling of youth-friendly health services to the remote areas through mobile services have increased the participation of the young people. Consultation sessions with community leaders such as the headmen, the church leaders, and the youth leaders in targeted areas facilitate the participation. So prior to going out into these communities, we first had our consultations with the leaders of those communities. And then increased knowledge on contraceptives and safe sex will result in the decrease of unintended pregnancies. During our outreaches, we also created small group discussions, and we found that the communities enjoyed those intimate discussions very much. Okay, so for our recommendation, so it's the City of Windhoek's responsibility to make sure that HIV education and the availability of services are readily available for both the young women and men in all residential areas. So we already have a few council resolutions that allow us to do that. And then definitely addressing the language barrier. So we know now from this first attempt in going out into the community, we have to spend much more time in translating the material and also on promoting the activities. And then what we have to do early next year is to explore ways how to track the young people that have left school due to unintended pregnancy. We have a program specifically for young teenage mothers or pregnant teenagers, which will start then early next year, and then they will fall into part of this as well. And then online platforms and mobile services to remote areas to encourage services, to make services available to everyone. I think that's that. Yep. Thank you.
Thank you, Melissa. Thank you, Melissa, for your presentation. We'll now have 15 minutes for questions, comments. Okay, I can see that someone there. Please. Yes.
I hope I can find the question. Yeah, for Maputo. You always seem to sweep me off my feet. The last time we met in Johannesburg was your PWEED project, and now it's your male engagement program. But I want to know, what are the linkages between these males and with the MSM community, and also what is the linkage between with people who use or inject drugs as well, or is it only just focusing on PMTCT? Does it also cover other populations of males? And also just want to really say, well done on getting men. I think we have a lot that we can learn as South Africa. We have a lot of campaigns, we have a lot of funding, but I don't think it's been placed in a well-appropriate place as you have demonstrated. So we have a lot to learn from you. Thank you.
Thank you. Another question? Iman, right
Yes.
there? From Blantyre, then after Blantyre. You can go, yes, you can go.
Okay. Thank you. I have several, but maybe I'll just ask two. I had a question for each city. For Kinshasa, I hope you can still hear us. I was just interested to know who is the disclosure happening to, especially the one being done over video conferencing. Is it being done to family or other peers or, yeah. And then for Maputo, again, but to all the cities, indeed, well done. To Maputo, how did you mobilize the men, especially for being engaged in the PMTCT program? And then for Nairobi, the cities that are leading integrated services, are they managed, I mean the health facilities, are they managed by the city or the county? I'll stop here, thank you.
Thank you. Imanu, please. Blantyre.
Yeah, thank you for great presentations that we've had this afternoon. My question goes to Etequin. It has to do with the political, political engagement, where we've talked about World AIDS committees. So I wanted to find out how this instituted and what is the composition of these World AIDS committees. Thank you.
Thank you so much. My name is Tinashe Grateful Furuwadzo. I'm the Director of Programs, Management and Governance with the Global Network of Young People Living with HIV. I have a question for South Africa in terms of the meaningful involvement of people living with HIV. I just wanted to find out if there is any involvement and engagement that is also happening with young key populations living with HIV, particularly young people identifying as LGBTIQ+, young people who sell sex in all their diversity, and young people who use drugs. And there was also a mention on lack of disclosure. I just wanted to find out if there is any peer-to-peer model that you have been using or maybe learning from to support with that process. Then for DRC, I also realized that from the case studies, or maybe it's something that I might have missed, young people, they seem not to be a homogeneous group, and I just wanted to find out on how are you also dealing with young people from key populations who were born or who then contracted HIV at a later stage in terms of disclosure in their relationships to their partners as well. Then the same questions also goes to Namibia on the adolescent girls and young women. How are you looking at the diversity of adolescent girls and young women, particularly those who identify as queer, as lesbians, and if you also focus on AGYW who identify as transgender? Thank you.
Thank you. Cape Town.
Good afternoon. Question for the City Council of Maputo. So you were saying that you have all of these programs at the facility for men. My question is, how did you get the men to come to the facilities to participate or to enjoy the services that you offer? Did you do any advertising on the radio, media? And then second question is, to what extent was the political sphere involved in promoting the men coming to the clinic?
One more at the back.
Wangani Mzumar here from Malawi, HIV and AIDS Department, Minister of Health. Just a quick one for Maputo. Well done for the work you're doing. It's pretty remarkable. Just want to know, have you been able to get data on viral load suppression in terms of this, the males? Because I know you're getting them involved. How are you doing with the testing, the treatment, and viral load suppression, if you've got the data? Thank you.
I think that we can start with the answers. Itikweni, could you please start? Could you pass the mic? We have 2 questions for Itikweni.
Thank you very much. I'll start with the composition of the Ward 8 Council. We work, I think our presentation was clear to say we work at community level. So our Ward 8 councils are composed of sectors. We have 18 sectors, youth sector, men's sector, women's sector, labor, people living with HIV, business sector. Which one am I leaving, Slal? Yeah, there's 18 sectors in total. So at a ward level, the ward councillor is the chairperson of the Ward 8 Council. He leads, they sit in a meeting, then he calls all women who are doing women program. They compose a sector with different organizations. And then the youth sector, all young people who are doing youth programs in the ward. Same goes for PL HIV and in other sectors, NGO sector and other sectors. And then they elect people who are going to be sitting as a structure. There is a chairperson who is the ward councillor, and then the co-chairperson is the civil society person who is elected by the sector to represent them as civil society. And then they will have your secretary and your deputy secretary. So the membership comes from the sectors, but it is led by ward councillor and co-chaired by the civil society. It goes up to the district AIDS council, where the mayor is the chairperson and Dr. Nzimande here is the co-chairperson because he is the chairperson of the civil society in the city. So that's the composition. So they sit and deliberate on different issues that are happening in that particular communities, particularly issues of HIV, TB, and STI, and also teenage pregnancy. And the second question is if we have young people living with HIV, LGBTQI, and sex workers. LGBTQI is a sector. I've forgotten to mention it. Sex worker is a sector. So within the 18 sectors, we have LGBTQI sector. USAS is very active. They are establishing the sector because they have some people who are no longer active, but the sector, the task team is doing very well. They are in a process of launching the sector again, as well as the sex worker. Unogwanda is on the forefront. She's at that stage of launching. So we're about to launch other sectors, including the interfaith, because we also say we must be able to discuss these issues of HIV in our churches as well. So the interfaith religious sector is on the forefront. The last District AIDS Council, they were participating and fully on board. So yes, we have, that's why in my presentation you saw in Togozo, we have the PLHIV sector has chairperson who is Zonge, and the deputy chairperson is a young person, Unoglunga, living with HIV. So both her and Togozo are able to mobilize young people, including the young people in the LGBTQI sector who are living with HIV, as well as within the youth sector. We have a very active youth sector. I'm very proud to say, you know, our youth sector is on the forefront as well. Yes, we do have a model working with different partners, including TB/HIV care. Jenny is here. We have youth ambassadors, we have PA educators, we have facilitators who are conducting structural programs at community level and are able to have, you know, the one-on-one discussion with young people, and also working with the social workers with issues of disclosure. So the entire team consists of a youth ambassador, a PA educator that is also focusing on linkage to care, and also the facilitator who's able to take them through different sessions and different topics. And then you have your social worker who provides, you know, the support, and also the psychosocial support within the team. Thank you.
Thank you. We will now move to Maputo. We have 3-4 questions from Maputo.
Thank you so much for these questions. I think that I have a lot of questions to answer. I will do my best to answer. Well, I think the last question was about the virus suppression. Well, we don't have this data at our DHIS2 platform. We have a parallel information, parallel data that I don't have here, but in the formal data we don't really collect this information, but we'll do our best to really have it because it's very important. The Ministry of Health is helping us from the beginning. They launched in 2018. From then, they are helping a lot. They trained our health professional workers. Then they are monitoring and evaluating how Maputo City is going on in this male strategy, and the results are very good. About MSM, of course, we have focus on this group as well as a key population. We track risk behaviors because we have also people that are MSM in our health facilities to really improve our relationship with MSM. And also we offer HIV counseling and testing every 3 months with HIV negatives, and we offer invitation for the partners to test. We perform screening, diagnosis and treatment for STIs, tuberculosis and other chronic diseases. We advise for safe sex practices, and we offer condoms and lubricants to MSM. For the people that inject drugs, we advise for sex practices as well, and we provide condom. And we have one health facility in Maputo that are offering methadone for those that are taking heroin drug. And it's a very good approach for this kind of situation, and we are doing that. And also we are doing this screening for STIs, tuberculosis, and other diseases. And the last questions, how to mobilize these men to MTCT program. We are going to the radios, we are going to television, social networks, and we also do many meetings with the local leaders and religious leaders, because we understand that these people are the ones, the key interveners that will bring those people to our health facilities, and this is really helping us a lot. Thank you very much.
Thank you, Belia. Can we now move to Melissa to answer the one question for Windhoek?
Yeah. My question was, how do we relate with the young girls, LGBTQ, who identify as LGBTQ? So we do have, our team is well trained to work with these groups. So we do have focus groups where we do counseling as well as teach them about safe sex. However, in Namibia, our population for LGBTQI is not that big because there is still a lot of a taboo around it, coming from the religious side as well as from the political side. So unfortunately, people don't sometimes feel very safe to come out in fear of discrimination, all kinds of discrimination. So, but when they do come out, we do provide them with a safe space where they can feel safe and express themselves as they want to. Yeah. Okay.
Thank you. We will now move to our virtual online presenters. And we have one question for Kinshasa and one question for Nairobi as well. Dr. Faustine, could you please start? Can you hear us? Dr. Faustine? Okay, we can move then. Okay. Yes, we can hear you now.
Dr. Foster is received emergency. So I work with him.
Okay, so you are going to answer the question?
I do my best to answer.
Okay. Okay, we are
about video conference. The young who is far, we use video conference to discuss with him.
okay, but thank you. I think that we can discuss with Dr. Faustin later to have more details on the answer, but thank you anyhow. Finally, we'll move to Nairobi. There was one question for Nairobi. Keep Lagat.
So thank you for the question. And just to answer is that in Kenya, we have what we call devolved system of governance, where we have the national government, but also we have the devolved county governments. And so Nairobi is one of the devolved county governments, and the boundaries within which the Nairobi city forms also the county government. So when I'm talking about the city, we are talking about the county, the Nairobi city county government. So yes, we have facilities that are managed, or we consider them as public facilities that are managed by the Nairobi City County government, or these are the government facilities. But also we work closely with the private facilities, privately owned facilities, faith-based and NGO-owned facilities. So I think I've answered that question. So we have facilities that are managed by the public, that is the Nairobi City County government, but also the privately owned and faith-based and NGOs. And all these in terms of health coordination, the Nairobi City County government takes leadership, and all facilities that operate within its jurisdiction are supposed to report and work closely with the Nairobi Health Directorate within the city county governments. I hope I've answered the question. Thank you, and back to you.
Thank you so much. Thank you all the presenters for your time and for delivering the presentations. Our session, we reached the end of our session. I want to thank you all for being here with us, and I wish you learned as much as I did. Thank you. Enjoy the rest of your day.
Thank you.
Thank you, and bye.
Thank you.
same time facilitate
I am excited to present to you today on treatment coverage among key populations in 5 fast-track cities. And I will, assuming I will share my screen from my end. My presentation is on treatment coverage among key populations and looking specifically in 5 fast-track cities.
Yes?
So.
Hello?
Yeah, we can hear you. We've just started the presentations. So we know that fast-track cities around the world are working towards attaining the 95 targets by 2025, including the second 95 target, which is that people living with HIV who are diagnosed are on antiretroviral therapy. And in 2022, recently UNAIDS put out in their report that key populations accounted for less than 5% of the global population, but that they and their sexual partners comprised of about 70% of new HIV infections in the year 2021. And we know that reduction of new infections, key to reduction of new infections is ensuring that people living with HIV are on sustained antiretroviral therapy. So while many of the cities have made progress against the 95 targets, we have several cities that have actually attained the prior 90 targets as well. Closing the gaps to reaching 95 requires really understanding the subpopulation epidemics, particularly among the key and vulnerable populations that may have fallen through the cracks. So this study was an assessment of key population data We included 5 fast-track cities in the assessment. We included Amsterdam, eThekwini, which is also Durban, Johannesburg, London, and Nairobi. These cities were selected purely based on availability of data. And the next slide will talk about which indicators we were looking at. So the data sources, we had citywide estimates reported. There were direct reports from fast-track cities between 2019 and 2021. And the key population estimates, we had 2 sources. Some were, again, direct reports by fast-track cities between 2019 and 2021, and some were from UNAIDS AIDS info from 2017 to 2020. So these are the different data that we were specifically looking at. So for aggregate city data, one indicator not listed on here is we were looking at total number of people living with HIV in the city. We were looking at the reported proportion of people living with HIV on ART. And from this, we calculated the proportion of people living with HIV who are not on ART. For key populations, we looked at 3 different subpopulations, sex workers, MSM, and PWIC. We looked at the number, the estimated number of people living with HIV in each of these key populations. We looked at the proportion of people living with HIV attributed to each key population category. So for example, the proportion of PLHIV who are sex workers, or the proportion of PLHIV who are MSM. We looked at the proportion of PLHIV in each key population category on ART. So for example, the proportion of PLHIV who are sex workers who are on ART. And then we also calculated from this, we calculated the proportion of people living with HIV in each key population category not on ART. So for example, the proportion of people living with HIV who are sex workers who are not on ART. And then finally from this, we calculated what we define as a not on ART treatment burden, which essentially is the proportion of the relevant key population that's not on treatment out of all people living with HIV not on treatment. So an example would be, the proportion of sex workers who are not on treatment out of all PLHIV who are not on treatment. And this was kind of used to compare the proportion of, for example, the proportion of sex workers out of all people who are living with HIV, to see where some of those inequalities may lie in terms of treatment burden or lack of being on treatment. So first, looking at the data from sex workers, we were able to find this data for 3 cities, for Nairobi, eThekwini or Durban, and Johannesburg. And you'll see on the left side the graph, which is showing the proportion who are not on treatment. So we see in Nairobi that about 22% of people living with HIV are not on treatment, compared to 63.6% of sex workers living with HIV who are not on treatment. In eThekwini, we see about 30% of PLHIV not on treatment, compared to about 56% of sex workers living with HIV who are not on treatment. And in Johannesburg, it's a bit more equal. We see about 42% of PLHIV not on treatment, and about 41% of sex workers living with HIV not on treatment. But then when we look at the burden of not on treatment, and again, this is looking at the proportion of each key population category that are not on treatment out of all the people living with HIV who are not on treatment. We see that in Nairobi, 15% of people living with HIV are sex workers. However, sex workers living with HIV contribute to about 44% of all people living with HIV and not on treatment. And we see that kind of inequality there. And at eThekwini, it's a little less drastic, but a similar trend where only about 1% of people living with HIV are sex workers, but sex workers living with HIV contributed 2% of all PLHIV not on treatment. And in Joburg, we see the flip actually, where 77% of people living with HIV are sex workers, and they contribute to 71% about 71% of all people living with HIV not on treatment. Looking at men who have sex with men, we were able to find these data for 3 cities, for Nairobi, Amsterdam, and London. We see that in Nairobi, there's quite a big difference between the proportion of PLHIV not on treatment and the proportion of MSM not on treatment. There's 22% not on treatment among all PLHIV and about 67% not on treatment among MSM living with HIV. But in Amsterdam and London, these values are a bit more equitable between people living with HIV and then MSM living with HIV. Then when we look at the burden not on treatment, we see in Nairobi that 5.24% of people living with HIV are MSM, and MSM living with HIV contribute to 15.7% of all people living with HIV who are not on treatment. So we kind of see that inequity there. In Amsterdam and London fare a bit better. Amsterdam actually quite a bit better when we're looking at MSM, because we see that about 73% of PLHIV are MSM, but MSM living with HIV contribute only 50% of all the people living with HIV not on treatment, meaning that actually the general population or population that is not MSM actually contributes more to the burden of people who are not on treatment. In London, it's pretty equitable with about 53% of people living with HIV are MSM, and MSM living with HIV contribute to about 52% of all PLHIV not on treatment. Then lastly, looking at people who inject drugs, we had these data for Nairobi, and we'll see again, there's a difference here between the people living with HIV on treatment, that's 22%, or sorry, proportion of PLHIV not on treatment is about 22%, compared to PWID living with HIV not on treatment is about 81%. And here also we see that only 3.25% of PLHIV are PWID. However, PWID living with HIV contribute to almost 12% of all people living with HIV who are not on treatment. So this was a pretty small assessment with just a couple of cities. Very hopeful that we're able to, do a similar assessment, including several more fast-track cities in the future, particularly since UNAIDS in their most recent target updates has called for key population specific data, and it will give us a better sense of where some of these gaps are. And in some cities, we see that key populations are significantly falling between the cracks, and large proportions are not on treatment, or there's a discrepancy between the actual, number of key population category in a city compared to, how much of that key population is actually not on treatment. And achieving the 95 targets and ultimately working towards zero new HIV infections and epidemic control, it really means that we need to be looking at these disaggregated data that can strategically inform HIV programming and help us close the gaps. So I will stop there. Thank you.
Thanks a lot, Ravi Shankar, for that presentation. I think very exciting and also very clear in the context. I think one big follow-up is just to, I think particularly on the last one, particularly in terms of the data gaps, what is it that is actually leading to that sort of lack of data in some of the cities while the others do have, I think, on a complete sort of data sets?
Yeah, that's a great question, and I think it comes really down to also within the national and municipal health systems, just kind of strengthening the efforts. to be able to collect these disaggregated data and collect the key population data. And I do think those efforts, there's been a start of these efforts for sure. And particularly, I mentioned the most recent targets update from UNAIDS for the 2025 and 2023 targets, or sorry, 2030 targets. We are seeing data disaggregated by specific key populations. So I am, hopeful that we'd be able to do some more of these kinds of analyses in the future.
Thanks a lot, Ravi. I'm sure there will be more questions for you at the very end if you happen to be still available with us. But I think in the interest of time, we'll then move on to our second speaker. We'll now hear from Tiffany Glenn, who will speak to us about the HIT Syndemic, a new status neutral framework of the HIV epidemic among transgender women to guide eradication efforts. Tiffany, the floor is yours. And you'll introduce yourself in about 1 minute before you dive into your presentation. Please go ahead.
Ready to go, just waiting on the slides. All right. So, hi everyone, my name is Tiffany. My pronouns are she, her, ea. And as I'm sure some of this audience is aware, despite advances in HIV prevention and care, transgender women continue to face an HIV epidemic. They're about 50 times more likely to be living with HIV compared to everyone of reproductive age globally. And they're also not benefiting from biomedical advances that we have. They're less likely to receive and uptake PrEP and ART, have worse adherence, and also have poorer viral suppression. And it's really important to note the within group disparities, that even among transgender women, Black trans women, Indigenous trans women, Hispanic and Latinx trans women, and other trans women of color all have higher rates of HIV compared to their white counterparts. So the critical question to answer then is, what's driving this HIV epidemic among transgender women? Yet specific factors unique to this group and translation of such factors into a holistic framework to guide prevention efforts is understudied. And also, given that there's such high HIV incidence and prevalence among this community, I think there's a need for a status neutral framework so it can be applicable to both trans women living with HIV at risk for forward transmission and also trans women not living with HIV at risk for HIV acquisition. And also having one framework to include everyone also does not stigmatize, people by separating out by serostatus. And so this is where the HEAT Syndemic was born. HEAT stands for the HIV epidemic among trans women. And the HEAT Syndemic was based on two existing evidence-based frameworks. And these frameworks have been used to explain HIV and other health disparities in other marginalized groups. And this is syndemic theory and the minority stress model. And a syndemic model posits that these multiple epidemics that marginalized groups face work together and then make each other worse. So if you look at the purple circles in the slide, this is what I call established syndemic conditions. These are the epidemics that have been shown to affect all marginalized communities affected by HIV, including mental health, substance use, poverty, child abuse, partner violence, and incarceration. And all of these things interact with each other, and they also drive HIV risk. However, trans women not only experience these epidemics, but they also have unique conditions, unique epidemics that they face. And this is what I call the unique syndemic conditions, and you can see it in the pink here in this slide. And these are the gender minority stressors that trans women face, the chronic things they face due to the marginalization of their gender, like discrimination, stigma, rejection, non-affirmation of their gender, meaning no access to hormones that they want, not being able to change their name or gender on identity documents if they want to. So the HEAT Syndemic proposes that we need to consider both of these types of epidemics, these syndemic conditions, together to explain this more complex HIV epidemic among trans women. And all of these conditions keep each other alive and also lead to biobehavioral HIV acquisition and transmission risk. So the goal of this study was to see if the heat syndemic would be empirically supported by data from the lived experiences of trans women. And so this is, to test the heat syndemic, the HEART study was conducted for the past 2 years. And this study included 81 trans women from Miami, Florida, USA. And just to note, Miami is a hotspot of HIV in the United States. It has the highest or second highest HIV incidence and prevalence. So this study took place within a group with an HIV epidemic within a geographic region with an uncontrolled HIV epidemic. And it's also very important for me to note that this study was developed and run with and by the trans community in Miami. And this study included a psychosocial survey in English or Spanish, and also we did HIV testing and HIV viral loads. So first, I looked at the prevalence of all the syndemic conditions that we saw in that circle as a check on the applicability of the chosen constructs for the heat syndemic. In other words, are trans feminine people actually experiencing the conditions that were put into the heat syndemic? And as you can see, the sample had high prevalence of nearly all established syndemic conditions. I mean, if you look at economic marginalization, drug use, partner violence, child abuse, those are all over 50%. And all the others, mental health, substance use, all of that, they're all really high. And then also looking at unique syndemic conditions, these were also pretty ubiquitous. This sample experienced really high rates of discrimination, rejection, non-affirmation of gender, internalized stigma, all of these things. Then I looked at the correlations between all the syndemic conditions as a check on the framework's assumption that all of these conditions are interrelated. And if you see here, any colored circle represents a significant correlation. So all syndemic conditions were significantly associated with at least one other syndemic condition, with most of the conditions associated with multiple other ones. Then I did some bivariate associations as a check on the assumption of the framework that it can be status neutral, meaning applied across both HIV serostatuses, and also within the context of BIPOC disparities, meaning can this also be applied across race, ethnicities, and skin colors? And so if you see here, there really wasn't much difference between syndemic conditions and HIV status. Out of 16 syndemic conditions, only one was significantly different. And out of syndemic conditions, there was no differences between race and ethnicity, and only one difference between skin color for syndemic conditions. So this is showing us that this model can be applied even within the context of within group disparities and also a status neutral framework. So then the main models, I did a series of generalized linear regressions to examine the association between number of syndemic conditions experienced and biobehavioral HIV risk outcomes. And this was an empirical check of the proposed framework because the framework posits that the more syndemic conditions that you experience, this would increase HIV risk. So I looked at 3 HIV risk outcomes: condomless sex, sex work, and needle sharing, and all of those not protected by adherence PrEP or viral suppression. And we found that as number of syndemic conditions increased, there was a greater likelihood of condomless sex and recent sex work. Needle sharing I wasn't able to look at because the prevalence was too low in the sample. I also want to point out that HIV status and race and ethnicity were not significant covariates, further supporting that this framework can be applied ubiquitously to all trans women. And then on the right side, you'll see that I did some discriminatory power analyses, meaning how well does the model do if we just look at established or just look at unique or look at them combined? And the best models indeed were the ones that looked at the established and unique conditions together, meaning we need to look at both of those types of conditions in order to explain the HIV epidemic among trans women. So in summary, the data supported the heat syndemic. Trans women did indeed experience these multiple epidemics noted in the model. The multiple epidemics were associated with each other, and HIV risk behavior was directly associated with how many of these conditions someone experienced. And it showed that this is appropriate to use as a status-neutral framework and also across race, ethnicity, and skin colors. However, it's not over. Based on a lot of informal qualitative information collected during study procedures, the trans women were observed to experience and also reported experiencing what a construct we'll call life chaos. And life chaos is really the instability and unpredictability in daily life due to marginalization. For example, a lot of them couldn't make their appointment at the last minute because of transportation issues or last minute conflicts due to like an economic opportunity that came up like sex work. And also life chaos has been shown in some other literature to be related to, like, say, HIV medication adherence. So we also measured life chaos, and using a causal inference approach, we also found that life chaos played both a mechanistic and a driving role of the relationship between the number of syndemic conditions experienced and HIV risk behavior. So this is the final heat syndemic framework, right? Epidemics that cross-cut populations plus unique conditions that trans women face interact to drive biobehavioral HIV risk via this life chaos. And these conditions notably take place at the systems level, the community level, and the individual level. And to be clear, the heat syndemic is a product of marginalization, intersectional marginalization, and systemic power and privilege issues. So, in summary, trans women cannot benefit from HIV interventions if the context of their lives and the system is not addressed. So a multi-level, multifaceted approach is necessary to address the complexity of the gaps in the HIV prevention and care cascade. And hopefully the heat syndemic provides a potential blueprint for such HIV prevention efforts and the pursuit of health equity, which is needed to meet any of the HIV-related goals that we have. And to the left, the figure represents the intervention at macro, meso, and micro levels that we need to do in conjunction to address this really complex heat syndemic. A quick example of a macro level intervention would be anti-discrimination laws, free and easy access to gender affirmation, promised economic opportunities for trans women. Argentina is a good case study of this. An example of meso-level intervention would be trainings or requiring providers to be gender-affirming, clinics to be gender-affirming, and trauma-informed. And then, although to be quite clear, the burden for intervention should not be on the trans women because this is a systems problem. Because systematic change takes so long, we do need some micro-level interventions at the individual level, like tailored substance use and mental health services. And of course, I just want to acknowledge all the participants firstly, and all my community partners in this, and of course my funders that made all this happen.
Thanks a lot, Tiffany, for your presentation. And I think you present a very strong case there for, there are many things that we tend to ignore when we concentrate only on the HIV epidemic, but of course, they need to pay attention to all the other syndemic factors that equally play a role when it comes to the mental, but also the stability of all our teams that we do work with. So that's a very wonderful presentation. I'm sure the audience has taken note of all those points, and there will be many questions for your follow-up. So to help me, I think, catch up with a little bit of time, I will then call upon my third speaker. Tiffany, I assume you're still with us until the very end. So I'll call upon my third speaker, Melanie Bisnoth, who will speak about understanding disengagement and re-engagement in Johannesburg's HIV program and analysis of clients reinitiating ART. Melanie, the floor is yours. We can't hear you.
Check.
Yeah, we can now hear you.
Yeah. Thank you. Good afternoon, colleagues and friends. Thank you for this very valuable opportunity. My name is Dwi Octavia. I work for Jakarta Provincial Government Office. And in this session, allow me to share experience regarding scaling up viral load testing in Jakarta through customization of the national HIV cohort platform. May I have the slide, please? Yes, next slide, please. Okay, sorry. Yeah. Just before around October 2022 in Indonesia, we still use web-based HIV information system called SIHA version 1.7. The system did not yet accommodate recording and reporting for viral load testing on individual record and made it difficult for us to calculate the third fast track goal, which is 95% people living with HIV on ART has viral load suppressed. The Jakarta Public Health Office viewed this gap and needs to get a systematic response to capture the viral load test comprehensively by the system, starting from PL-HIV as individual data in HIV services who are eligible for the viral load test. Then the health workers notify the eligible patient to test and receive the result afterwards. Currently, new HIV information system called SIHA 2.1 version is being developed. In response to the challenge, Jakarta collaborate with Epic Indonesia from USAID as one of the partners in providing technical assistance in Jakarta and also in national level. With intensive technical working with the Ministry of Health, we developed cohort recap application called ARK, capture facility antiretroviral therapy registered data to track individual people living with HIV across yearly ART cohorts. Through this ARK, HIV services can collect the following individuals' data, starting with ART initiation and regimen. ART outcomes include retention, death, loss to follow-up, and the re-engaged patient in treatment, and then viral load testing and suppression. ARK is able to track and identify the PL-HIV who are eligible for viral load testing, where health workers very easily by clicking the features of eligible viral load tests can produce the list of individual data of patients who are eligible for the viral load test in the defined time period. The eligible criteria for viral load tests refer to WHO and Ministry of Health guidance are HIV patients who have been on ARV treatment for 6 months, 12 months, and multiple thereof. Jakarta has been implementing the viral load test since the policy of viral load testing accelerated in July 2018. Currently, 125 facilities in Jakarta has been used ARK and report the viral load data there. This image showed the trend of viral load coverage in January 2019 to March 2021. Before COVID-19 pandemic was happened, the trend of viral load coverage was significantly increasing from 37% to 90%. When COVID-19 has been detected in first week of March in 2020 in Jakarta, the trend was decreased, became 58% and continued decrease in 23% in the end of third quarter of 2020. It was because PL-HIV were facing high risk to access the facility. They tend to not showing to health facility, and some facilities has changed the service to prioritize the COVID-19 patient. With this situation, the Public Health Office collaborate with the Epic to develop an innovative strategy called Check Antar. It's a home-based ARV delivery system. After this strategy implemented, the trend of viral load coverage was going increase into 72% in Q4 2020 and 76% in Q1 2021. Unfortunately, it was decreased in Q2 2021 due to the availability of viral load test kits. The trend of viral load suppression kept stable at above 87%. District Health Office and Public Health Office Jakarta is able to monitor the trend of viral load coverage and result through ARK every month, year, and across a year. In 2019, to improve the achievement of viral load examination in Jakarta, we developed JAK Transporter to serve as an alternative to referring patients to the lab, making it easier for patients and increasing viral load test result. JAK Transporter works by dividing into 5 regions according to the topography of the area in Jakarta. The graph shows the number of viral load samples delivered from October 2019 to May 2022. There was significant increase in the transport of viral load specimen from early to late 2021. In December 2021, due to year-end issues, many patients went out of town and were unable to do viral load tests. There was a decrease shows in the graph and an increase gradually again in January to May 2021. Strategies to address the specimen transport gap called JAK Transporter, a travel-based viral load sample delivery system. By dividing the group of facility according to geographic location to maximize efficiency and speed up to keep samples safe and secure, less than 4 hours from collection time to be received in the laboratory. On average, 4 to 5 clusters per district. There are 8 special transporters working in Jakarta in 5 regencies. Each manage 2 to 3 referring services at 1 cluster per day. Based on the graph that shows the increase of viral load tests on the previous slide, it can be concluded that customization is key for JAK Transporter that eliminates hassles from previous system. The lesson learned of ARK utilization in Jakarta, within 1 year, 100% of the facilities could now regularly report viral load testing and suppression data. The second is since July 2018, over a 3.5-year period, 18,894 viral load tests were conducted with an overall 93% suppression rate. Approximately 78% of total eligible PL-HIV in Jakarta had received at least 1 viral load test by March 2022, while only 3% were reported having a viral load test in 2018. At site level, analysis of viral load test eligibility and coverage allows to identify sites with poor achievement and prioritize those sites for focused technical assistance. A close follow-up of viral load coverage trend during this period allowed to document the impact of the COVID-19 pandemic on viral load tests. By the end of 2022, it is expected that viral load testing coverage among all PL-HIV in Jakarta will exceed 85%, far above the 45% MOH targets. As a conclusion from the implementation of ARK and viral load specimen transporter or JAK Antar in Jakarta since July 2018, Jakarta Public Health Office will continue to use ARK and expand it to more treatment facility in order to build more accurate and comprehensive 95 HIV treatment cascades. Thank you. That concludes my presentation.
We can't hear you, Robert.
Yeah, I think we should go to the next one. The next person is virtual.
Okay, the sound is now back. We had lost the sound.
We can hear you now.
Okay, perfect. So, well, thanks for your presentation. Unfortunately, we missed quite a number of your last comments there, but thanks for sharing the experience from Indonesia, particularly I think the strategy that you put in place during the COVID crisis and having tested it and obviously worked very well. So again, we do look forward to a lot of follow-up questions towards the very end of the session. But up next, we can then move to Martha Teijema for your presentation. And
Yes.
Martha will be speaking to us about towards zero new HIV infections in Amsterdam in 2026, reaching undocumented migrants for HIV and STI testing and linkage to care. Martha, the floor is yours.
Yes, thank you, Robert, and thank you all who still made it here in the afternoon. First of all, I'm here representing an organization working with undocumented migrants, and together with the Public Health Services of Amsterdam, we organized a program with reach-out actions or outreach activities to test undocumented migrants for HIV and STI. This was the whole title of our project. So what am I going to do today? So I will take you along a little bit on the content of this project and also the data gathering that we combined it with, on which we provided a study. So first, we all know about the 1990 goals. And in Western Europe, and then zooming in on the Netherlands, we actually reached these goals in 2020 with 92%, 94%, and 97% of these goals. And this is for the Netherlands at large, so not necessarily for Amsterdam. There's still, we're making good progress, but there's still a lot to do because we have still 1,540 people in the Netherlands living with undiagnosed HIV. And of these 1,540 people, about 36%, so about 560 of them live in the largest 4 cities of the Netherlands, which is Amsterdam, Rotterdam, Utrecht, and The Hague. And of those 560, about 300 are estimated to be living in Amsterdam. And I noticed there's a typo in this slide because we were hoping to get 0 new HIV infections now in 2022. No, it's 2026. So I made a typo and a bit of a hope and a dream, I guess. So why did we look particularly at undocumented migrants? Well, as some of you here might know, migrants are at increased risk of HIV. And this is partly because of endemic countries that people migrate from, but unfortunately, the majority of the people actually contract HIV either during migration or in the host country after migration. So this is an important group of people that we have to look at. And at the same time, what we notice is that migrants are less frequently tested for HIV than people in the host countries as well. And that combination, of course, is potentially problematic. And the reason for this uptake of testing, or this diminished uptake of testing, has a lot to do with experience barriers. And they can be, for instance, that people are not aware of where they can get tested. They don't find their ways to the public health services, but also stigma plays a role, or lack of also knowledge from healthcare providers, how to deal with migrant populations, especially undocumented migrants. These barriers, you can imagine, are even higher. So what did we look at? Well, we actually analyzed the outcomes of a project of outreach HIV and STI testing activities of an NGO, Doctors of the World, together with Public Health Services of Amsterdam. And we did this in collaboration with several migrant organizations. And the data collected through this, we analyzed to see if there are certain characteristics that can inform us on how to actually reach undocumented migrants better for HIV and STI testing. So what did we do? Between May 2021 and January 2022, we actually organized several outreach activities. Some of them were the NGO Doctors of the World alone, and some of them were a combination where on site, but I will inform you a little bit more about that, we did HIV and STI testing. And there we go. It was obviously organized in collaboration with a lot of migrant organizations. And I think part of what we all got from yesterday is the importance of really including the community that you're working with in also your program, and that's exactly what we did here. So there's a whole list, and for the non-Dutch speakers here, which are a lot, the Pauluskerk is a church, and some of the other organizations are all particular migrant organizations with representing a specific group of people living in and around Amsterdam. So how did we actually get to work together? Well, it was network that we worked with, and then through snowballing we actually collaborated also with more migrant organizations. Prior to these outreach testing days, we had a stakeholder meeting, first with all the migrant organizations that we knew, and after that we actually sat together and spoke with each other to see how we could best organize these testing days. So what would actually work for the group that we were going to test. And there was a questionnaire actually that we also discussed with the organization, and we would do this prior to the actual testing with the migrants who were actually at the testing days. Obviously, this questionnaire was not obligatory, so even if people wouldn't want to do the questionnaire, they would obviously still get tested. And then the questionnaires combined with the testing results, we collected and analyzed afterwards. So what did we actually do? Okay, we had 28 outreach activities, of which, in which we actually tested 126 people for HIV and STI. And as you can see, that's quite resource intensive, and I'll get back to that later during when I'm explaining some of the recommendations. The mean age of the people we tested was 37, and we actually had quite a lot of male and quite a lot of female and a few transgender people that we tested. But the actually very interesting figure is that we had 52 people who actually tested for the first time for HIV. And if you look at the number out of the 126, I think that's a very good result. And 19 people actually tested for the first time since migration. So that's both also given the fact that most people contract HIV after migration. I think that's a very good result to highlight as well. Here's a bit of an overview of the countries of birth of the people we tested. And I hope you can read it a little bit on the slide, or that your geography is very on par. But it's, especially there is some people also from very high endemic countries such as Brazil. The STI tests then, what did we find? Out of the 126 people tested for HIV, there was 0 new HIV infections found. Then with the STI tested, we did 49 tests on the STIs that you can see: chlamydia, gonorrhea, syphilis, hepatitis B and C if indicated. And out of this, there was 5 people that tested positive for chlamydia, and that was the only positive results from the tests. So what can we take away from actually these outreach activities? As I said, they're very resource intensive because we wanted to adjust the testing activities to the particular people that we were testing. And that's an important thing, especially when we speak about migrants. It's obviously a very, very heterogeneous group. And we have to be able to adjust whatever we do to the specific people that we are working with. And that is the important notion, especially when you want to really find these last 300 positive cases in Amsterdam. It is going to take time and effort and resources to actually get there. And in addition to that, what you can also see in the outcomes, we found 0 HIV positive cases and 5 positive chlamydia cases. Of course, this was a small sample, but in addition to that, we also asked a lot of questions about sexual behavior, and we actually think that the group of people we currently tested didn't show very much high-risk behavior when it comes to contracting HIV. And it's also supported by the data on STI. And then the last point actually is something we already mentioned. The collaboration is key to really reaching the people that we want to reach. And so from there, we can actually bring the 3 recommendations here. So invest time, resources, and effort in really building bridges with the different migrant organizations within your city. And do this in a particular way that suits best for the different organizations. And build trust. Often, especially when it comes to stigma or when working with undocumented migrants, people are afraid when it comes to working with public health services that they're connected to the government. I might be, in one way or another, there might be a link that people find out that I'm actually living undocumented in this country. So building trust is really an important part. And we also hope that given these collaborations, we might end up working together on the long term. And then that also comes to the last part where, again, the people we work with is a heterogeneous group. We cannot say, oh, we are going to test undocumented migrants because who are they? And in order to really do that, I think the most important thing, again, are these collaborations and sustainable collaborations and really making it a community-led way of testing and working together. And then before I go to the questions, of course, I would like to thank all the different organizations that worked with us. And actually, the photo is one of the meetings we had prior to actually doing one of the outreach activities. And I think this is a very important part of the recommendations we want to give along. So that was my presentation. Thank you.
Thanks a lot, Martha, for that wonderful presentation. I think presenting a very unique case there of working with undocumented migrants. And of course, trying to understand how they are coping, but also responding by their own HIV status. I'm sure, again, my audience has been listening in very keenly, and you'll be receiving quite a number of follow-up questions later after we finish up the presentations. So up next then, I will invite Melanie, if you're able to connect.
I think so. Can you hear me?
Yes, we can hear you now. So Melanie, please go ahead. Introduce yourself very quickly, and then you can dive straight into your presentation.
Apologies to the room for the connectivity issues. And can you see my slides?
Yes, we can see them.
Okay, perfect. So thank you, Robert. My name is Melanie, as he's mentioned. I am a public health technical advisor at Innova Health Institute. We support the Department of Health over in Johannesburg, South Africa. So today I'm going to be presenting on understanding disengagement and re-engagement in Johannesburg's HIV program, an analysis of clients reinitiating ART. So So there are no conflicts of interest to disclose. And these are the contents of the presentation I'll be running through. So there are 500,000 persons living with HIV in the city of Johannesburg alone. When you look below on the graph on the slide, an estimated 66% are currently on ART. Of those not on ART, 79% are aware of their status. There are 24% of PL-HIV not on ART and do not know their status. Therefore, we need to look at the cascade when we think about the 395s in a very different way when targeting interventions, especially for those individuals that may interrupt treatment and re-engage in care. So the ratio between returning clients and new initiations on ART is increasing. Therefore, interventions and resources should shift in the same direction. We know that from the National Department of Health over in Joburg that 26% of people returning to treatment in 2021 were made up of restarts. Long-term ART adherence is needed to achieve and maintain viral load suppression. Therefore, disengagement and re-engagement are increasingly recognized as a small part of lifelong ART. PL-HIV, they do not move through the cascade as through a series of steps, but it's more dynamic. Here on the right, you'll see this revolving door, and this indicates that disengagement and re-engagement can and do occur at all different time points. So one of the biggest priorities for South Africa's HIV program is returning lost PL-HIV to care and to reinitiate or reinitiate ART. Inova Health Institute supports Johannesburg Health District's implementation of the Welcome Back campaign, also known as WBC, and its activities to encourage interrupted ART clients to re-engage. This started back in 2019 and was relaunched during the COVID-19 pandemic in 2021. The WBC aims to encourage PL-HIV back to care by the following. So you'll see here, training healthcare workers on the Médecins Sans Frontières, also known as MSF's welcome approach. Here featured on the top right, which includes 5 components. 1 is welcoming the patient to this service to make them feel valued. 2 is normalizing their struggle with treatment and reducing their guilt, having disengaged. 3 is acknowledging that they have returned to care and build upon this achievement. 4 is supporting them in ways that they need to adhere to their treatment at the individual level. And 5 is empowering them to take ownership over their health. Media messaging, including radio, posters, pamphlets, and social media, were also featured in this campaign. Here on the right is an example featuring our slogan, "Your time is now. Your health is in your hands." Along with this, healthcare facilities and community activations took place in primary healthcare centers and community healthcare centers across Johannesburg. Lay counselors assisted with navigating clients reinitiating ART at Johannesburg's public health care facilities. They were asked to complete a 1-page form with questions during the reinitiation process about demographics of the client, duration of the treatment interruption, reasons for interrupting, returning to care, and the choice of their clinic, and the exposure to the Welcome Back campaign adverts. We report on forms captured into RedCap, which is an online database system, and that was between the months of August to December 2021. And chi-square tests for categorical data associations were conducted to help identify the differences between the age and sex groups. So results revealed that 377 forms were captured between the months of August to December of 2021 in 18 facilities across 4 regions of Johannesburg. 60% of our clients were women, 39% were between the ages of 35 to 44 years old, 38% interrupted ART for more than 12 months. So this was very alarming. 33% interrupted ART for 3 months or less. When comparing why did clients disengage versus why do clients re-engage, we saw that mobility and relocation was reported by 31% as the top reason in the city of Johannesburg and across all our sub-districts. This was followed by distance to the clinic, was too far, reported by 19% of our clients, and difficulty getting time off work, reported by 17% of the clients. About 20% reported clinic-related reasons of why they disengaged. So this included, for example, transfer letters, which a client needs in order to access care at another facility when moving between, long waiting times, and being sent to the back of the queue. When looking specifically at why clients re-engaged, 47% represented the top reason that was provided, and that was about worried about being off ART. This was followed by access to services becoming easier, reported by 21% of our clients, and feeling sick, reported by 23%. When we look at why did clients disengage by gender, reasons for interrupting treatment differentiated between men and women. When we look at the bar graphs below, the stars indicate a p-value of less than 0.05 for statistical significance. Mobility was reported as the top reason in women at 33% and men at 30% for disengaging in care. Scared to come back, anxiety in returning had a p-value of 0.04, reported in women only. Women also cited disclosure issues at a p-value of 0.04. Privacy and comfort in the healthcare environment is very crucial in retention and when dealing with disclosure. It's also important to note that these clients were asked by counselors, and it may have been difficult for them to be honest about poor staff attitudes that they experience within the facility. When we look specifically at men, 19% reported time off work was a reason for disengagement at a p-value of 0.01, and 13% reported change in employment at a p-value of 0.03, and 6% reported they forgot. We see again here mobility as a top reason across all our age groups for disengagement in care. The stars below again on the graphs indicate a p-value of less than 0.05 for statistical significance and for the difference between the age groups. We see here 25 to 44-year-olds and 45 and older. Change in employment was a reason for interrupting, a top reason, sorry, for interrupting treatment. Under 25-year-olds reported more often fatigue, which we see in 11% of our clients at a p-value of 0.05, and 10% who forgot at a p-value of 0.01. But what does forget mean? Were they unwilling to share other reasons, as mentioned in reporting to lay counselors when completing these forms? Furthermore, 25 to 44-year-olds stated believing ART doesn't work at a p-value of 0.01, and 45-year-olds and older cited waiting times at a p-value of 0.05 for reasons of interrupting treatment. What did clients request to support their adherence? So we want to further investigate this to target our interventions. No single intervention was requested by more than 28% of our clients. We see that 28% requested counseling and support groups, and this was followed by SMS reminders at 26%, and 24% requested check-in phone calls. So what are check-in phone calls? So this was a more proactive strategy that goes beyond just a follow-up reminder from our retention counselors. It's asking the client how are they doing on their treatment and really probing them. Therefore, a mix of interventions are needed to support adherence for different people. We also see food support, and there was a good panel discussion yesterday about this, about really being able to support our clients that come into the facilities holistically. So disengagement from ART in Johannesburg is driven by both shifting life circumstances and health system barriers. More respondents felt worried when they were off ART, highlighting the importance of the barriers to continuing treatment. We can modify our services to address the needs of different client groups at the individual level to support long-term retention and quicker re-engagement following future treatment interruptions. Health services need to keep working toward being supportive of clients and not punish those reinitiating ART, instead normalize interruptions in life events like moving and changing jobs that do occur. We should really focus our areas to include increased flexibility and efficiency in our services, providing support, education, and also mentoring peer counselors, providing disclosure support. And this can really cater to positive staff attitudes. Transfer letters should not be needed and pose substantial barriers for access, and more enabling health information systems are needed for clients on the move. We know Johannesburg There's a very mobile population. Clients move between clinics, the regions, and provinces with unpredictable lives, and therefore a unique ID and network system would be beneficial in tracing these clients on the move. Also advocating for 12 months prescription, maximizing your DSD and MMD with external pickup points, including community pop-ups to collect treatment. We saw this during the pandemic. People want different support methods, and this includes case management, SMS reminders, and food support. So to conclude, we just like to acknowledge MSF, Welcome Services, and the Johannesburg Health District for their support, and also the participants, facility staff, and management for allowing us to conduct the study and welcoming us. And we'd like to thank USAID. Thank you.
Melanie, thanks a lot for your wonderful presentation.
Thank you.
And we will then move next to Karen. Karen will be speaking to us about the quality of care for people living with HIV and AIDS across seven fast-track cities, particularly assessing the interpersonal communication with health facilities. Karen, the floor is yours, and use about 30 seconds to introduce yourself.
Thank you so much, Robert. I'm just trying to share my screen, but I think it's going to be very helpful if I'm able to share it from that end, because it seems I'm unable to. Are you able to see my screen?
No, not yet, but you can try again.
Is there anything now?
Not yet.
I think I may have a glitch on this end.
Okay, did you share your slides with the
Yes.
IT team?
Yes.
Okay, maybe the IT can project your slides then. Challenge is we can't see your slides if they project it on their side, but we can see and hear you and hear what you say. I won't be able to see your slides.
Let me try one last time.
Or Karen, what you might want to do then, I'll just put you last, then we can hear from Helen. Okay. As the IT team also sorts out. But you can also email me your presentation, and I could try and project it from my side. But I think in the meantime, let's move on to Helen as we sort out the technical issues and glitches on your side. So Helen, if you can hear me, please, you can go ahead to share with us the HIV provider perceptions of COVID-19 disruptions in HIV service access in Lagos State. Helen?
Okay, thank you, Robert. I think I need to give the technical team here a minute to put up my slides. Should I go ahead and present without my slides being up?
Yeah, I think I can go ahead and introduce yourself.
Okay, yes. I'm Helen Omowumi Oluwofeso. I am Senior Manager for Strategic Information at IAPAC and the Fast Track Cities Institute. And I will be speaking today, like Robert said, on the HIV provider perceptions of COVID-19 disruptions in HIV service access within the city of Lagos.
Okay, let me know once the team projects your slides. For us online, we are unable to see your slides, so that's the disadvantage. But we can hear what you say.
Can you see my slides now?
No, on our side, we can't see them because of a technical issue on that side.
Yeah, it's up now, actually, so I would imagine that you can.
Yeah, you can go ahead and present.
Okay. Thank you, Robert, and thanks to the IT team. As we all know, COVID-19 came and most health systems across the world had to sort of grind to a halt momentarily and re-strategize on how healthcare providers were being allocated to various services. And this paper was examining what happened in Lagos and how health providers themselves actually were able to, or what they thought and how they were able to perceive the situation. During the pandemic, a lot of countries and health programs had to make very difficult decisions in terms of balancing the demands of responding directly to COVID-19 whilst still providing or simultaneously maintaining HIV and other essential health services delivery, as well as also protecting healthcare providers and other auxiliary personnel. You can go to the background slide, please. Oh, sorry. Actually, that's me. Thank you. Sorry. A lot of health systems were tested for resilience, and we all know that resilience is the ability to prepare for, manage, and learn from shocks. And what COVID did was actually shock every one of us for the most part. And across the world, we had multiple dashboards, multiple surveys. A lot of teams were looking at things slightly differently and to see what effect COVID was having on service delivery across board, including in the context of HIV prevention, care, treatment services, as well as services around sexual and reproductive health, mental health, tuberculosis, malaria, nutrition, and etc. So what we tried to do with this survey at the time was to understand the perception of healthcare providers within the city and across also 15 other cities that are supported by the USAID grant on the Fast Track Cities, 15 Cities project. And we wanted to see what happened, the realities and how we can develop strategies to mitigate these disruptions should they occur again in future. The survey in this case was a multi-stakeholder survey, which we're just trying to use to synthesize disruptions. Multi-stakeholder in this case being various cadres of healthcare providers. So in terms of the methodology, it was a cross-sectional survey conducted in Lagos, and we had about 85 healthcare providers take part in the survey to assess their perceptions of how service delivery in the HIV space was disrupted. It was a 22-question survey, and we used a Likert scale questionnaire system over a 1-month period. We ran this sort of simultaneously because in terms of the implementation of the actual 15 Cities project, we started implementing within COVID and had to be very agile in our approach to delivering our trainings, which we did virtually. And as part of the virtual training systems, the survey questionnaire was implemented at the end after healthcare providers had gone through about 9 different modules on the different aspects of HIV service delivery. And the training covered a lot of HIV capacity building as well as stigma elimination training for healthcare providers. The survey was examining essentially their perceptions on how COVID-19 affected the health system and how prepared the Lagos State health system was, and how also at the time, how prepared we were and what level of preparedness we're going to be having in the future for, God forbid, any other pandemics. And some of the questions that were covered included the impact of COVID-19 on the health systems, and we examined the level of disruption for testing, treatment, retention, viral load testing, the factors that were contributing to these disruptions, what exactly was happening. I mean, people couldn't move, we were locked down, so lots of appointments physically were cancelled, diverting a lot of medical staff from regular service delivery into emergency services, also diverting a lot of resources into COVID-19 resiliency plans and all of that. And there were tons and tons and tons of supply chain issues. I have my CEO seated here, and she can attest to this, and how we had to be very agile in modifying our approach to service delivery within this context of HIV. There was also a lot of shortage of equipment, because a lot of the equipment being used for testing in the HIV space was also now being used for COVID-19 testing, etc. And also there were tons of demand issues contributing to HIV service disruption. So we tried to evaluate a lot of these disruptions with questions that examine the impact of COVID on the health system. We also try to examine vaccine resiliencies and issues contributing to the availability and the rollout of the COVID-19 vaccine, what infrastructure we had in place in terms of the cold chain. A lot of the vaccination that happens in the context of Nigeria and Lagos at the moment, or prior to COVID, was usually around maternal, newborn, and child health for the most part, and then there was the peripheral other bits of vaccinations that were necessary for maybe travel and things like that. But we had to re-examine how the things were then affected in the context of COVID-19. And also, of course, the vaccine hesitancy, lots of conspiracy theories, even among healthcare workers, societal myths, and all of those things also had to be examined, because beyond individuals being healthcare workers, doctors, nurses, midwives, etc., there are also individuals who live in communities who have very strong societal expectations, societal beliefs, myths, and conspiracy theory, Instagram, Facebook, and the rest, who were not really helping matters, no matter how informed a lot of people were, or health workers were. There was also us examining preparation and planning of the actual system in and of itself, the role of community healthcare workers. Lagos is a city that has over 20 million people living in it, and we have a lot of brain drain in terms of healthcare providers. So there's a lot of community healthcare workers doing quite a lot of stuff, from para training that has happened, that also IPAC has supported in the past. There's also the role of, we also had to examine the role and the uptake of virtual health, telemedicine services, and also differentiated service delivery, and how we then adapted it into the context of COVID-19 at the time. So the results we found across healthcare workers were, we first also had to just look at the cadre of healthcare workers who took the survey at the time. We had initially trained over 400 of these healthcare workers, and only about 85 of them did take part in the survey. And of that number, about 58% of them were actual physicians with MBBS or MD degrees. So 24% of them were nurses, 10% of them were pharmacists, and 6% of them were community healthcare workers. And in terms of their perceived perception on moderate to severe disruption for essential services, about 60% of them believe that viral load testing was thoroughly affected. And adherence to ART regimen also, 46% of them believe that a lot of their clients and patients were affected in terms of their adherence to services, to the ART regimen. There was also the context of retention in care being very closely linked to adherence and new initiation of ART. In the case where the country was locked down, there were lots of cases of individuals not being put in care as quickly as would have been normal prior to COVID, and we had about 58% of health providers suggest that there were moderate or severe disruptions to this as well. With HIV linkage to care after a positive HIV test, this was one of the highest concerning indicators, because the city also rolled out HIV self-testing around the same time, and if a person had then turned up with a positive self-test, how quickly they could be linked to care was impacted, and healthcare workers also believed this from our survey. And HIV testing services, in terms of actual blood tests, were thoroughly affected, as we see from the results here. We also had the top 3 reported causes of observed disruptions. The first and the highest, the highest cause of observed disruption was diversion of staff. to COVID-19 emergency services. Within the city of Lagos, there were quite a number of emergency service centers, and while there were lots of volunteer healthcare workers, lots of people in the health systems also had to step up and play their part to curb the pandemic. And we also see that there was staff shortages due to COVID-19, quarantines and illnesses among staff. A lot of people obviously took ill, healthcare workers, people within communities, maybe not as much as what we saw in other parts of the world, but there were significant numbers within the health system that meant that there was shortage of service delivery generally. There was also obviously cancellation of appointments. 82% of healthcare workers believe that a lot of their appointments were cancelled, and this goes without saying, right? When there's lockdown, prior to COVID, we're not as technically welcoming as we now all have to be. We're here in a virtual...
Helen, you have about 1 minute to summarize up.
Oh, I'm almost done. And yeah, well, on the final bit of results we were examining, there was obviously the health provider perception of health systems preparedness, and 78% of the respondents of this survey believe that establishing community outreach mechanisms to ensure service delivery of essential services in communities where people live is very essential. To conclude, and in terms of our recommendations, the ability of health systems to plan for and provide differentiated care services cannot be overemphasized, and we've seen that in the past 2 years. Understanding the impact of the pandemic on delivery of HIV care and treatment is key for urban response preparedness for future crises and ensuring health systems remain resilient. Data will always inform the development of a framework for resilient urban HIV responses to future crises. And moving forward, there's a need to continue strengthening systems in place to facilitate community engagement in service implementation and monitoring, visit spacing and multi-month dispensing, HIV self-testing, and telehealth and medicine. Thank you very much.
All right, Helen, thanks a lot for sharing those experiences, particularly coming in from the healthcare providers. We still have one more presentation to go, and we'll now hear from Karen, who will speak about quality of care for people living with HIV across 7 fast-track cities, particularly looking at assessing interpersonal communication in health facilities. So Karen, the floor is yours. Let me know if you're able to project or if you want me to help out on that.
Thank you, Robert. I'll just try one more time, and if not, I'll ask for your assistance.
Sure.
Okay, Karen, we'll project and I'll move your slides for you, if that's okay.
Helen, I already sent my slides to Robert. His concern is the people online will not be able to see the slides, but if that works, that's still fine.
Oh.
Okay, let me know if
okay,
you're
then
able
Robert
to
can. Robert can. Okay, can you see your slides now?
Yes, thank
Lovely.
you.
I'll send you an invoice.
Apologies to everyone for that glitch, and I send my greetings to you all. I would like to thank you for your participating in this satellite session and taking time to listen to our results from the QOC survey. Essentially, the quality of care survey is running as part of our joint UNAIDS IAPAC 15 Fast Track Cities project. Next slide, please. So funny, this slide comes after this introduction, but my name is Karen Chale. I'm Associate Director for Strategic Initiatives at IAPAC. Next slide. Thank you. So as previously mentioned, the QOC survey is one of our key objectives as part of the joint UNAIDS IAPAC 15 Fast Track Cities project, which is now in its 5th year of implementation. And this survey aims to assess the quality of care provided to people living with HIV in 15 urban settings. So in order to fill this survey, we obtained local IRB approval from for our protocol through each of the city's national ethics committees. And in each of the cities, as per the protocol, we fielded our survey across 25 facilities, both public and private, with anywhere between 55 to 100% of these facilities being funded by PEPFAR. So we expect that our individual city reports will provide some specificity regarding types of health facilities and patient caseloads as needed. I would also like to highlight that in terms of time frame, the survey was fielded during the COVID-19 pandemic. The fielding started once cities began lifting their bans, and we did make sure that we adhered strictly to municipal risk mitigation measures and regulations. So overall, our survey explores the quality of care received by people living with HIV across 8 domains. These domains include HIV understanding, HIV counseling, linkage to HIV care, engagement in HIV care, AT and AT adherence, secondary HIV prevention, whole person care, as well as interpersonal communication, which will be our focus for this presentation today. So I will cover data on interpersonal communication to provide a little bit of insight on what the results are telling us so far in 7 of our cities. Next slide. Okay, thank you. So the 7 cities being presented today are Kigali with 421 respondents, Lusaka with 487, Maputo with 422, Yaoundé with 408, Lagos with 582, Kinshasa with 476, and Jakarta with 410. So for the sake of clarity and comparison, we have divided these cities into 2 regions. We have Western Central Africa, as well as East and Southern Africa, and then Jakarta, which will stand alone. Looking at our age distribution, you will notice that the majority of our respondents ranged between ages 25 to 49 in West and Central Africa. And then you also notice that we have an age range of 18 to 39 in ESA region, with an exception of Maputo, where the majority of our respondents were older than 30. Next slide, please. When we look at our gender demographics, we observed similar trends across both regions, with women taking up most of our respondents, ranging from 47 to 70 across both regions. Next slide. So now we look at the demographics of Jakarta, which is our standalone city. Majority of our respondents ranged from 25 to 49 years of age. And in terms of gender, majority of our respondents were male at 61%. Next slide, please. So we now delve into our interpersonal communication results. The survey explored patient-provider relationships with significant emphasis on stigma and discrimination experienced in health settings. We asked about feeling unwelcome at their health facility, and majority of our respondents reported not feeling unwelcome across 5 cities. Yet it is still important to note that 13 to 28% of our respondents from the cities in West and Central Africa cities reported feeling unwelcome, and this was between 12 to 15%. And in ESA, the same applies. A similar percentage of respondents reported feeling unwelcome in Jakarta. Next slide, please. Again, the same percentages can be seen across all age categories, with 10 to 30% reporting not feeling welcome in their health facilities, which although is lower due to ongoing stigma elimination activities by a number of partners in the cities, but we do see that this is unacceptable and needs our attention. Next slide, please. Equally, we see similar trends arising in Jakarta. Next slide. So looking at gender versus reporting having felt unwelcome in their health facilities, we do notice that men were more likely to report having felt unwelcome in West and Central African countries. And in the ESTA region, you will notice that the trend changes with slightly more women in Kigali and Maputo reporting feeling unwelcome. And when you come to Lusaka, there's no significant difference across the genders. And the same applies to Jakarta, which is in the next slide, please. Oh, sorry, it's just right there. Next slide, please. So in conclusion, the results emphasize the urgent need to improve healthcare providers' verbal and non-verbal interactions in health facilities. It is imperative that we ensure that there's a safe environment in health facilities that enables PILL HIV, specifically key populations, to fully express themselves without prejudice and receive quality care that is specific to their needs. Equally as important is also the establishment of platforms that encourage two-way dialogue between healthcare providers and PILL HIV, so we can have collaborative efforts as we identify the best interventions. It is also important and crucial for sensitization, targeting community health workers on various forms of communication and how they affect patient experience and in turn adherence to treatment for people living with HIV. Last but not the least, mapping interpersonal communication approaches and practices and identifying gaps on each step of the care continuum would benefit stigma and discrimination policies and interventions that aim at improving quality of care in these health care settings. Thank you.
Thanks a lot, Karen, for that wonderful presentation, of course, coming in last but not necessarily least. And I think from all the 7 presentations, we've had a good round of many experiences, almost a tour of the whole world in terms of what is ongoing. And with a few minutes that we might have, we've shot over time, but we can at least open the floor for any quick questions or remarks that the audience might have. So please let me know if you have any questions for my panelists and presenters today. In the room, I can't see the hands, but you can hand over the mic.
Sorry, I was running over for the microphone. So I'm Tom from Amsterdam. And I actually have to many presenters, I'm kind of left with the question, how? So there were a lot of conclusions about, the whole system, about migrant testing, but also the last one about interpersonal communication. And I'm thinking, okay, we have conclusions that we should do better, but how do we move on? I'm a policy advisor, so I'm not the researcher, so I'm left with the conclusions of the research thinking, okay, so how do I move on then? How do I make it better? So if anyone feels like picking up the baton, let me know, because that was kind of my main puzzle that I'm left with.
Thank you for your question. So I think it's an open question for all of them. So each can have at least 30 seconds to respond to that.
30 seconds. Well, that's longer than an elevator pitch, so that's good. But the how, I think when it comes to the undocumented migrant testing, I think collaboration, and that is really keeping your network active. So we did this project with the public health services, and we connected with a lot of organizations, and I think that would really be the how, like connecting and keeping these connections through stakeholders meetings, to actively engaging people in continuing these kind of outreach activities. So that would be the how, organizing stakeholder meetings and connecting. Was that within 30 seconds, Robert?
Yes, Martha, it was. Thanks a lot. I think we can hand the floor to Tiffany, who is right next to you.
I think I commented a bit like that. This is what I call macro level interventions, these policy changes. And I think for trans women specifically, these are the things. We can take some case examples from Argentina and some Latin American countries where they put policies in place where trans women are getting reparations, these economic reparations, right, for the discrimination and stigma that they faced. And and that economic marginalization is one of the cogs in the wheel. And so if we can have policies that, one, create anti-discrimination laws, right? That's one cog in the wheel, that give economic means to trans women, education, actual money, actual income. That's another cog in the wheel. And two, provide free universal access care, healthcare, mental health care, right? For me, those are the big policy things that need to be changed for trans women as far as their HIV epidemic.
Thanks, Tiffany. Helen, your thoughts?
The how in terms of preventing further disruptions is just learning from what we've already, the reality we've lived in. Health systems and, health systems essentially we can plan, we can do better with our contingency planning and putting things in place. We would see the things that didn't work and the approaches we used to address them at the beginning of the pandemic, and how we were eventually able to iterate and internalize those learnings to make them into a system that works. And we can then institutionalize those things, put policies in place for those approaches to remain and to get better, I think. I hope that sort of answers your question.
Thanks, Helen. Let's hear Dui's thoughts on that.
Thank you. I think in my opinion, the key is the agility of the organization to identify strength and role of each parties that can contribute to solve the problems, and to collaborate, and also to make specific measurements in order to see the improvement that we can have after the course of projects.
Karen?
Well, honestly, speaking to interpersonal communication, we all know that stigma is a very difficult thing to address. I did not know if there's any of us that have the response on how to address some of these challenges. However, I would say expanding our outreach activities would work. For example, as Fast Track Cities and the network, we're doing some outreach activities on stigma and discrimination in terms of capacity building of healthcare providers as well as our community folks. So more importantly, one of the things that I think would be crucial is to actually put the people that are affected at the center of these interventions. For example, the key populations. I don't know if that equally addresses the issue sufficiently.
Excellent. Thanks a lot, Karen, for those inputs. Let me know if there's any other question on the floor. Those in the room can alert me if there's any hand on the floor.
There's no hand.
Okay, excellent. So I think we've done a very wonderful job sharing quite a number of a wide range of topics, and I feel as your moderator today, there's quite a number of big takeaways. I think from the COVID pandemic, we've learned a lot. We've also learned a lot of efficiencies. I think we've learned a lot in how to even improve in terms of service delivery. What I also heard today is that we've also learned from the health providers, but we've also learned from our clients what exactly is keeping them onto the service or pushing them away from the service. And I think all these key lessons need to be tied down into one big picture of improving service delivery and basically reaching that last person who needs all our services. And I feel also very strongly that the component of partnerships, particularly listening from the migrants' story, there's nothing that we might be able to do alone, but we need to work together, both with those we serve, but also with many partners, including those that sit at the vertical and the horizontal levels of governance. So I feel those are all wonderful lessons that we need to take forward, tie it perhaps into good policies that can then offer better services. And if we do that, I think we're going to be able to achieve all the targets of our Fast Track Cities initiative. So from me, once again, I want to say very big thanks to the presenters for having stand up and shared your wonderful experiences. I think a lot of it very much evidence-based, both from the quantitative and qualitative. It was such a rich story that you told today, and we do look forward to further engagement with all of you, but perhaps also working with you to see how we can move a lot of this from research to policies that can change lives for people. So from me, thanks a lot, and for the organizers as well, a big thanks for having pulled through this session, and we do look forward to further engagement in the remaining sessions of the conference. Thanks, and have a wonderful evening, as well as a good morning or a good afternoon, wherever you might be connecting from. Thanks, and bye-bye.